Recording in progress.
Je pense à un truc. Lourd. C'était lourd.
C'était lourd, mais c'est bon.
Je crois que c'est bon. J'ai pas le temps de vérifier en fait. Son. On doit désactiver le son chez eux. quand même le faire.
Ladies and gentlemen, welcome to the Royal Academy of Medicine of Belgium. The session of today consists of a half-a-day symposium centered on advances in breast cancer. It is to the pleasure of Professor Martine Piccart and Frédéric E to have organized this event and convinced high-level international and national speakers to be with us today. It is, of course, traditional for the Academy to have usually a lot of people physically present, but with the introduction of the Zoom and YouTube, now the session will have these three components: the attendance here in the Salle Roi Baudouin, and then we have academicians on Zoom and public on YouTube. And this is what is managed very, very well by Ms. Vanessa Costanzo, to whom I give the floor to explain a little bit the technical aspects to all participants.
Thank you, Mr. President. And if you don't mind, Mrs. Morrow, I will continue in French just to explain everything to people. Donc la séance a fait l'objet d'une accréditation avec le micro. Avec le micro, c'est mieux. Bonjour à tous. La séance a fait l'objet d'une accréditation INAMI, comme toujours, et je vous précise en fin de matinée, quand vous envoyez vos emails. Comment la rendre interactive? Eh bien, vous commencez à avoir l'habitude. Pour les académiciens qui nous suivent sur Zoom, merci d'indiquer dans le chat vos questions et de nous donner la possibilité de vous donner la parole et donc de vous connecter en tant que panéliste. Il suffit de cliquer sur OK quand on vous envoie la demande. Si vous nous suivez sur YouTube, c'est via le chat que vous pouvez poser vos questions aux orateurs. N'oubliez pas de nous mentionner votre nom et votre affiliation. N'hésitez pas à poser des questions, n'hésitez pas à partager aussi des expériences avec vos patients. L'intérêt est vraiment, lors de ce genre de conférence à l'Académie, de mettre en commun. Et c'est de chirurgie que nous allons parler pour débuter cette matinée. La dissection axillaire, autrefois très courante, a aujourd'hui cédé du terrain à d'autres pratiques. Quelles sont les indications résiduelles en 2022? Monsieur le Président, c'est une oratrice venue spécialement des États-Unis pour l'Académie qui nous en parle au travers de ses recherches.
It's a great pleasure and honor to introduce our first speaker, Professor Monica Morrow from the Memorial Sloan Kettering Cancer Center in New York. Dr. Morrow is a distinguished alumni of both the Pennsylvania State University and Jefferson Medical College. She has been trained at the University of Vermont in residency and then fellow at the Memorial Sloan Kettering. She took upon faculty positions in 1988, Associate Professor of Surgery at the University of Chicago, and in 1993, a Professor of Surgery at Northwestern University. She is an honorary fellow of the Royal College of Physicians and Surgeons of the Royal College of Surgeons of Ireland. She is now Chief of Breast Cancer Surgery at Memorial Sloan Kettering. She is an editor of 3 breast cancer textbooks and has published an impressive number of papers, editorial, book chapters, and others, almost 600. So we are greatly honored to have Professor Monica Morrow here and look forward to your conference.
Thank you very much. It's a great pleasure for me to be here, and I appreciate your hospitality and the ability to return to in-person life again after COVID. These are my disclosures. So when we think about management of the axilla, things have changed dramatically from the era when we routinely performed axillary dissection for all breast cancers with at least a 25% risk of lymphedema, to the adoption of sentinel node biopsy as a staging procedure and subsequently as a therapeutic procedure for patients with limited amounts of nodal disease, having both upfront surgery and surgery after neoadjuvant chemotherapy. And in 2022, the questions we're beginning to ask are whether or not in the era of molecular medicine in breast cancer, we need to stage the axilla at all, or in fact, does personalized medicine require now that we go back to knowing the precise number of lymph nodes that are involved with cancer? So as a background, when we think about the use of sentinel node biopsy for staging, we now know very clearly that you can find a sentinel node in more than 95% of women with breast cancer, that this reliably identifies metastases, and even though the false negative rate of sentinel node biopsy ranges from 5 to 10%, the likelihood of axillary first recurrence is less than 1%, something I will ask you to keep in mind as we think about the use of this as a therapeutic procedure. And of course, as a staging technique, this has no survival impact. Now, a number of things happened 10 or so years ago that caused us to ask the question of whether or not we could decrease the extent of axillary surgery. Namely, breast cancers are smaller, the nodal disease burden is lower. We recognize that just as the risk of systemic failure is a function of the biology of the tumor, so is the risk of local failure, and that the number of lymph nodes involved with cancer rarely determines the type of adjuvant systemic therapy used. And not only does radiotherapy contribute to local control, but so does systemic therapy. So when we think about indications for axillary dissection, we need to break things down into those patients who are undergoing initial surgery and those who are having surgery following neoadjuvant chemotherapy, an increasingly more frequent scenario today. So if we look first at upfront surgery, we have 4 prospective randomized trials that ask the question of whether sentinel node biopsy alone in the case of the IBCSG and the ACOSOG trial, or sentinel node biopsy plus nodal irradiation in the case of Amoros or Odo-ASAR was equivalent to axillary dissection. Notice that all of these studies included patients who had metastases in 1 or 2 sentinel nodes, and although additional nodes were present in the axillary dissection arm in between 13 and 39% of patients, 10-year rates of nodal recurrence were 2% or less, and there were no survival implications. So what this says is, just as we saw with false negative rates in node-negative breast cancers, that the vast majority of nodal disease which is left behind in the axilla is controlled with systemic therapy and radiotherapy. When we see nodal recurrence, it tends to happen within the first 5 years. And importantly, this approach applies to patients with metastases in 1 or 2 sentinel nodes. We don't know whether or not it works in those with a heavier disease burden. But the bottom line is that axillary dissection can no longer be considered standard management for patients who meet the eligibility criteria for these studies. Now, although it seems somewhat hard to imagine today, when these were first published, they were extremely controversial. And there was a question of whether or not this applied to the bulk of patients with breast cancer or was for a highly selected group. So this is a prospective study that we did looking at patients who met the Z11 eligibility criteria, were clinically node negative, found to have sentinel node metastases. There were 793 of them, and we were able to avoid axillary dissection in 84%, which represented a dramatic change in clinical practice for us. So there are several issues that were not addressed in the clinical trials that lead people today to continue to question the need for axillary dissection. That is, what do you do with patients who have abnormal axillary imaging? How about those who have a needle biopsy that shows cancer in a non-palpable node? Does this apply to high-risk patients? And do histologic features such as microscopic extracapsular extension or extranodal tumor in the axillary fat indicate the need for dissection? So if we look first at abnormal axillary imaging, we at Memorial do not routinely image the axilla of our patients, but many patients come to us having had these studies done. So this was a group of 425 patients who met the criteria for Z11 or amorose and had undergone axillary imaging either with ultrasound or MRI or not. And all of these patients were found to have positive sentinel nodes. You will notice that in a patient with normal axillary imaging, dissection was necessary for 3 or more positive sentinel nodes in only 12 or 13%. If the imaging was abnormal, it was necessary in about 30%. So what that means is if you were to triage patients to axillary dissection purely based on seeing abnormal nodes on imaging, 70% of your axillary dissections would be unnecessary overtreatment. Not a good idea. So what about somebody who has a positive needle biopsy of a non-palpable node? Does that indicate the need for axillary dissection? So here we're looking at the combination of imaging findings on ultrasound and needle biopsy, and you see that if you have a single abnormal node on imaging and a positive biopsy, 43% of these patients required dissection for 3 or more positive nodes, so again, a minority. If you have more than one abnormal node, that number goes up to 68%, but still, almost a third of patients do not require an axillary dissection. So we do not consider this an indication for upfront axillary dissection unless you see imaging that shows the axilla is full of multiple abnormal nodes, and it's very uncommon to have that when the clinical exam is normal. So what about those who are so-called high-risk breast cancer patients? The trials of this approach were primarily done in postmenopausal women with hormone receptor-positive breast cancer because that's who gets breast cancer, and most breast cancer is hormone receptor positive. So we looked at women less than age 50, or those with HER2 positive or triple negative breast cancers to see whether or not the rates of axillary dissection in that group were higher than in women age 50 and older with hormone receptor positive breast cancer. And as you see, they were identical. And in those who required dissection, the nodal tumor burden was not different. So this applies across all subsets of breast cancer, not just to ER-positive postmenopausal women. So we next looked at histologic features such as microscopic extracapsular extension. So as you will recall, matted nodes, meaning gross extracapsular extension, were an ineligibility criteria for these clinical trials, but there was no comment on microscopic extracapsular extension, which is illustrated here. Here's the node capsule in the black line. The yellow and the red mark tumor growing outside the capsule. So what we know is that the presence of extracapsular extension, as we demonstrated in this study, is an indication of a heavier nodal tumor burden. If you don't have it, only 3% of patients will have 4 or more involved lymph nodes. If you have less than 2 millimeters, that goes up to 9%. But when you have more than 2 millimeters of extracapsular extension, a third of patients will have 4 or more additional positive nodes in their axillary dissection. However, in a study where we did not do axillary dissection for those patients, this did not translate into an increased rate of recurrence in the node fields at 5 years, as shown on the top line, or an increased rate of distant metastases, as shown in the bottom line. Now, of somewhat more concern to us was the presence of extranodal tumor in the axillary fat as a potential indicator of the need for axillary dissection. And in this case, we see that if you have extranodal tumor, more than half of patients have 4 or more involved additional lymph nodes at axillary dissection, compared to 10% who do not have this finding. So a marker of a heavier disease burden, but what this really indicates is the need for axillary radiotherapy following sentinel node biopsy rather than axillary dissection. So we've been talking about breast-conserving therapy because the overwhelming majority of patients who had this approach of de-escalating the axilla underwent breast conservation. But what about patients who are undergoing mastectomy? And there are two trials which have asked this question, which are not reported out yet. One is Posnock from the United Kingdom and the Senemac trial from Europe. And notice that in the experimental arm of these studies, there is no axillary treatment beyond sentinel node biopsy. So this is asking the question, how much local control can you obtain purely from systemic therapy, not with any radiotherapy? And the endpoints of these studies are axillary recurrence or breast cancer-specific survival, and they will provide us with definitive information on management. But in the meantime, what do we do? When can axillary dissection be avoided in those undergoing mastectomy? And there is widespread agreement that for patients with micrometastasis, this is a safe approach. And for patients who have macrometastases in 1 or 2 sentinel nodes, if you know that you're going to deliver post-mastectomy radiotherapy, then this is the same approach as used in Amoros, in essence. It's just with a mastectomy, and that's safe. So the problem comes, how do you know who's getting post-mastectomy radiotherapy preoperatively? In some institutions, the finding of any disease in 1 sentinel node is an indication for radiotherapy. That is not the case at our institution. So we developed a rather complicated algorithm after locking ourselves in a room with our radiation oncology colleagues for a day and arguing about it. And we came up with a series of high-risk factors, very young age, triple-negative breast cancer, extensive lymphovascular invasion, and secondary risk factors derived from the clinical trials of post-mastectomy radiotherapy. And then how many risk factors you had to have depended on whether you had metastases in 1 or 2 nodes. But you will notice if you look at this list that only some of these risk factors are identifiable preoperatively: age, receptor subtype, tumor location, and an approximation of tumor size, but most of the rest are not. So because patients who have nodal disease, who have axillary dissection and then receive post-mastectomy radiotherapy are at the highest risk for lymphedema and morbidity, the goal is to minimize the combined use of those treatments. So we developed an algorithm that if you have 1 or 2 positive sentinel nodes and you have an indication for post-mastectomy radiotherapy, you don't have any further surgery. However, if there is no clear indication for radiotherapy, given that radiotherapy, particularly to breast reconstructions, is a morbid procedure, these patients go back to the operating room for axillary dissection. And for those with metastases in 3 or more sentinel nodes, axillary dissection remains routine. So we abandoned the use of frozen section in mastectomy and made this decision based on permanent pathology. And so we looked at the impact this was likely to have in a consecutive series of 2,000 patients undergoing upfront mastectomy. And what you see is that 87% of these patients had no nodal disease or micrometastases, so they didn't need a dissection. Of those with macrometastases, we were able to avoid dissection in 7%. We had to take 73 of them back to the OR, and a small proportion required dissection for 3 or more nodes. So the net message was we were now able to avoid axillary dissection in just over half of node-positive patients undergoing mastectomy by applying this algorithm. So to summarize what I've just told you about initial surgery, most clinically node-negative patients found to have sentinel node metastases who are having breast conservation can avoid axillary dissection. And axillary dissection is not indicated for those with 1 or 2 sentinel node metastases when it is clear that post-mastectomy radiotherapy is necessary. Features that we don't like in breast cancer that indicate a higher rate of distant metastases, such as young age and triple-negative subtype, do not predict a higher axillary tumor burden and should not be used as a priori indications for dissection. But microscopic ECE and extranodal tumor deposits do identify patients who are at higher risk for a higher nodal tumor burden who may benefit from nodal radiotherapy. And overall, our goal is to minimize the use of both axillary dissection and nodal radiation, or PMRT, in those with 1 or 2 sentinel lymph node metastases. And most importantly, axillary dissection remains standard for those with metastases in 3 or more sentinel nodes, regardless of what operation they're having, because there is no evidence on the safety of avoiding dissection here. So if that's upfront surgery, what about neoadjuvant chemotherapy? The use of neoadjuvant chemotherapy is becoming ever more frequent for a variety of good reasons, and that sort of changes our algorithm based on whether or not the patient is clinically node negative at presentation or node positive. So for clinically node negative patients at presentation, we have a prospective randomized trial, GANIA-2. We have several meta-analyses that include more than 6,000 patients that show that the characteristics of sentinel node biopsy are the same as they are for upfront surgery. We also have outcome data that shows that the nodal recurrence rate is less than 1.5%, and this should be considered standard practice. This, I think, is completely non-controversial. The controversy comes in the patient who starts out with nodal metastases and downstages to clinically node negative. Is sentinel node biopsy accurate, or does tumor die in different ways across the nodal basin? And does the sentinel node biopsy accurately stage the axilla in what may be drug-resistant tumor with a higher risk of local recurrence? And there are 4 studies that ask the question of how accurate is sentinel node biopsy in this setting. They're listed on this slide. You can see that they were largely patients with T1 to T3 N1 cancers, and the overall false negative rate in these studies exceeded the 10% that we consider clinically acceptable for upfront surgery. However, if we look at some details about how sentinel lymph node biopsy was done, you can decrease your false negative rate by using both a radioactive tracer and a blue dye to find the sentinel nodes. And most importantly, if you identify 3 or more sentinel nodes in all 4 studies, the false negative rate goes down less than 10%. And in this meta-analysis, you see that with 1 sentinel node, the false negative rate is 20%, clearly unacceptable. But if you have 3 or more, it goes down to 4%. So we asked the question, in someone with biopsy-proven nodes, how often can you actually avoid axillary dissection with neoadjuvant chemotherapy? And we looked at 630 consecutive patients. With neoadjuvant therapy, 573 converted to clinically node negative. We were able to find more than 2 sentinel nodes in the majority. And the other thing you need to avoid axillary dissection here is pathologic complete response in the nodes, which was present in 45%. Now, notice that, as we know for response in general, that PCR in the nodes was most common in HER2 overexpressing tumors and in triple negative tumors, and only seen in 20% of hormone receptor positive HER2 negative tumors. But overall, we were able to avoid axillary dissection in 41% of the patients who downstaged to clinically node negative, meaning on physical exam alone, after neoadjuvant chemotherapy. So until relatively recently, one of the main drawbacks to avoiding axillary dissection in this patient population was we had no outcome data. and there was concern that local failure rates would be higher. At San Antonio last year, we reported outcomes of our first 234 patients who downstaged at a median follow-up of 40 months, and we had no nodal recurrences in those who received RT. One occurred in a patient who refused the RT that they needed to get. The European Institute of Oncology has reported a series of 123 patients followed for 9 years with similar very low rates of local failure. So it appears that this approach is viable. We will never have data from the randomized trials on local failure because they all required axillary dissection. So in patients receiving neoadjuvant chemotherapy, 2 areas of controversy are: should you do an axillary dissection for very low tumor burden in the nodes, micrometastases and isolated tumor cells? And what if you don't get out the clip node? So if we look first at micrometastases, in patients who are undergoing surgery up front, we know that micrometastases in the sentinel node predict a low tumor burden in the rest of the axilla, 10 to 20%. But when you see isolated tumor cells or micrometastases after neoadjuvant therapy, you don't really know whether this is a low tumor burden or, in fact, it's the drug-resistant cells that just didn't die with the chemotherapy while the rest of the tumor went away. So to address this question, we looked at a group of patients who all had axillary dissection and saw that in those who had micrometastases in the sentinel node, 64% had additional nodal metastases, which was identical to what we saw in those with macrometastases. And we know that this low-volume tumor is biologically significant, as illustrated in this study from the National Cancer Database, looking at survival outcomes for patients who are completely node negative, shown in the top blue line. The best outcome, high volume residual node disease, N2 or N3 in the purple line, the worst outcome. But these 3 curves that are all lumped together are isolated tumor cells, micrometastases, and N1 disease. So nodal disease in the sentinel node of any volume after neoadjuvant therapy at this moment in time remains an indication for completion axillary dissection. So what about removing the clipped node? There is a great enthusiasm for marking lymph nodes when they are biopsied. In the United States, that's classically done with clips, so that after neoadjuvant therapy, you can be sure to get out that lymph node. And this was popularized by the group from the MD Anderson, who showed that the false negative rate of sentinel node biopsy plus removal of the clip node, which they call targeted axillary dissection, was only 2.4% compared to 8% for removal of the sentinel node alone. And what was most alarming about this study was that the clip node was not a sentinel node in 23% of cases. However, if we look at the published literature on this topic, all of which is essentially retrospective, you see that in these studies where the clip node was not a sentinel node in about 25% of cases, the technique of sentinel node biopsy was not optimized. Most of them did not use dual tracer. Most of them did not take out 3 or more nodes. We looked at this recently in something that is transposed on this slide so you can't see it. But with removal of a median of 4 sentinel nodes and 100% of patients having dual tracer, the clip node was a sentinel node in 88% of cases. So it is not our practice to clip nodes routinely. We do use dual mapping. If we have 3 or more sentinel nodes or a clip node plus 1 node, we do not dissect the axilla. And with this approach, our 3-year nodal recurrence rate is 1%, so we're fairly satisfied with that. So what about locally advanced breast cancer, and can nodal irradiation replace axillary dissection? So we know that rates of pathologic complete response in T4 tumors and those with advanced nodal disease are not different than in lower stage disease. They're driven by the biology of the disease, not the presenting features. But we don't know much of anything about the accuracy of sentinel node biopsy in advanced breast cancer because it hasn't been done much. And in a few small studies in inflammatory breast cancer, the false negative rates were abnormally high. So at this point in time, until actual data comes out, and we are about 2/3 of the way through a prospective trial looking at this, locally advanced breast cancer remains an indication for completion axillary dissection. Now, something we recently identified is that lymphedema is actually more common in patients who undergo neoadjuvant chemotherapy and then require axillary dissection than it is in patients who undergo upfront surgery. The multivariate hazard ratio is about 2. And this is after adjusting for all the things that we know are related to lymphedema. So we need alternative strategies to axillary dissection in patients who fail to achieve nodal PCR, which most notably are patients with ER-positive breast cancers. And so this has led to a great interest in the use of radiotherapy rather than axillary dissection. But I will point out to you that the residual tumor burden in patients who get neoadjuvant therapy is substantially different than it was in the trials of upfront radiotherapy, Amorose and Odoacor, where 33% and 39% of patients had residual nodal disease, but in studies after neoadjuvant therapy, that number is closer to 60%. So whether or not radiotherapy will be effective in this setting, we don't know. There are 2 studies that are ongoing in the case of Taxus, completed accrual in the case of the Alliance trial, that directly compare radiotherapy to surgery in those with residual positive nodes after sentinel node biopsy that will answer this question. So in summary as to what I told you about axillary management after neoadjuvant chemotherapy, in clinically node-negative patients, sentinel node biopsy results mirror those in upfront surgery. This is a standard of care. For those who start out node-positive and downstage, false negative rates exceed 10% unless you find more than 2 sentinel nodes. And because outcome data is still somewhat limited, I would classify this as an emerging standard of care. And axillary dissection remains standard for any residual nodal disease and in patients who present with T4, N2, or N3 disease. And at this point in time, radiotherapy is not proven to be equivalent to axillary dissection and radiotherapy for those with residual disease. So in conclusion, the indications for axillary dissection in 2022 for those with initial surgery, metastases in 3 or more sentinel nodes, those undergoing mastectomy who have only 1 or 2 nodal metastases and no indication otherwise for PMRT, and in those with palpable adenopathy, biopsy proven, who are not going to get neoadjuvant therapy, which is not very many patients, and after neoadjuvant therapy, as I just told you. I think what we can say overall about axillary management is that selecting the approach which minimizes the need for axillary dissection has become increasingly complex and requires multidisciplinary consideration of clinical nodal status, which breast operation the patient is having, ER, PR, and HER2 status, to decide whether or not upfront surgery or neoadjuvant therapy is the appropriate approach. But routine axillary dissection for nodal metastases is no longer the standard of care. Thank you.
Thank you very much for a very, very interesting presentation. We're going to open it to questions, and we're going to start with questions from the audience. Any questions? You have somebody will bring you, our staff will bring you the microphone. And we have a tradition that once you ask your question, then you will write a short note of it, so we have it in our archives. This is the tradition of the Academy. So questions from the audience? Well, while we get them, I just have a quick question. I remember a patient that was perfectly well. She just lost the ability to use this finger. So one day she came and said, I just cannot raise the finger. And it was because of an unknown problem in the axilla. Do you ever see this kind of very, very indirect signs of axillary involvement?
Well, axillary involvement that involves the motor nerves in the axilla is, and you're unaware of it, is quite uncommon, because that usually indicates disease very high in the axilla at level 3 or above the vein, which happens in isolation in about 1% of cases. So that would be an extremely unusual circumstance. Most of the time, you know, classic signs of inoperability, edema of the arm preoperatively, which indicates a heavy tumor burden, or neurologic signs certainly would prompt a metastatic workup.
Questions from the audience? If not, we can also investigate the digit. Well, Frédéric?
Thank you. Great talk. Thank you very much. Question from an imager. You mentioned the limitation of ultrasound and MRI. Is there any place for another technique from the nuclear medicine world, for example, in lymph nodes?
Well, I think the problem about axillary imaging is there is no technique, whether or not it's PET-CT, ultrasound, or MRI, that identifies very low volume disease. And it used to make sense to image the axilla when the presence of metastases in any node was an indication for immediate axillary dissection. But now we need to know how many nodes. So simply telling us that there's one node that looks abnormal, or even 2 or 3, given the fact that the false positive rate of imaging is high, and with the nuclear medicine techniques, they're normally done after somebody's had a breast biopsy, so that they have inflammation in their axillary nodes, they have low-level uptake in the nodes, and then you're still left in the same position of needing to do sentinel node biopsy. I mean, we could have a whole argument about whether or not in the future we care what sentinel node biopsies show at all, which I think is a different question. And then maybe imaging might make sense to exclude really bulky disease. But right now, we don't do it.
Thank you.
Any other questions in the room? Thank you. Thank you so much, Professor. Les techniques oncoplastiques de réparation ont connu...
We have a 1 second moment, because our perpetual secretary will offer the...
Les techniques oncoplastiques de réparation ont connu une très forte évolution au fil des ans. Les chirurgiens peuvent désormais minimiser les séquelles. Monsieur le Président, à vous l'honneur d'introduire un orateur qui, cette fois, nous vient de France.
Thank you very much. It's a great pleasure to introduce Professor Nicolas Leymarie from Institut Gustave Roussy in Villejuif in France. Our speaker today, he obtained his medical training at Université Paris-Cité, and then he done a master in surgical science at Université Paris-Est Créteil. He is an expert of reconstruction in breast cancer, but also in other pathologies. I think he worked also on sarcoma. He had some impressive reconstructing publications. He is now head of the Department of Plastic Reconstructive Surgery in the Institut Gustave Roussy. He is also coordinator at the European level of the Master in Surgical Oncology for Breast Cancer Reconstruction, and we are delighted to have him here. Thank you for your presence.
Good morning, everybody. Thanks a lot for the invitation. First of all, I would like to thank the organizing committee for the invitation. I'm very pleased and honored to be here with you today. So we will discuss about oncoplastic technique. As you know, over the last 2 decades, breast reconstruction techniques have been greatly improved and refined, while the expectation of the patient have increased at the same time. And advances in surgical techniques shift the goals of breast reconstruction from initially covering a large defect to reconstruct a symmetric, aesthetic, and functional breast that is close to a non-operated breast. So I would like to share with you three main innovations of breast reconstruction that have changed completely our practices in the last, I would say, 5 years. As you know, breast conserving surgery is still the reference treatment for breast cancer patients, and we offer this surgery for more than 75% of the cases. And for most of these patients, oncological outcomes, aesthetic outcomes are quite good, and it's the best option for them. But in some cases, when surgical resections are larger, when you need to perform radiation therapy, you can have this kind of aesthetic and functional sequelae that are very severe for the patient with a high impact on the quality of life. And if you look on the publication, on the data, and on your own results, you will see that these aesthetic and functional sequelae are quite frequent, up to 40% of the patient. So we need to find a way to avoid these bad results for the patient. So this is the idea of the oncoplastic technique that have been developed a few years ago. So the idea is to use the mammaplasty techniques, the breast lift techniques for breast cancer surgery, and to fill the defect due to the tumor resection. So by this way, you will avoid any defect, you will prevent the sequelae for the patient, and you will permit a wider tissue resection. And at the end, you will improve the aesthetic and functional result for the patient. For a long time, the way to choose for an oncoplastic technique or standard resection was depending only on the ratio between the size of the tumor and the size of the breast. And for example, if you have a ratio lower than 20%, no need for oncoplastic technique. And this is something that is outdated now. We consider more about the indication or not of mammaplasty reduction. For example, this patient had a very small breast cancer, but with a large and ptotic breast. So if you follow the classical principle of classical indication of oncoplastic technique, you won't perform breast reduction, you will perform just a lumpectomy. And for this patient, at the end, the aesthetic result is not so good. You still have a large breast with high volume of radiation therapy, and it's not so safe to perform a breast reduction after the radiation therapy. So if the patient is demanding for breast reduction, if there's a real indication of reduction mammaplasty, even in cases of small breast cancer, we will perform this reduction mammaplasty technique for the patient. And this strategy is well summarized in this publication of Douglas Macmillan and Stephen McCulley. So we choose the indication of reduction not only depending on the ratio between the size of the tumor and the size of the breast. So the ideal situation is this kind of patient with large breast, with an excess of volume, excess of skin. So for this patient, you will perform the classical inverted T mammaplasty. So you will choose the technique depending on the localization of the breast cancer. So this is the simplest situation. For this patient, you will obtain a nice breast, and if the patient is demanding, you can perform the symmetrization at the same time. For this group of patients with no excess of volume, just an excess of skin, you will perform a therapeutic mastopexy. So you will just adapt the skin envelope to the remnant gland of the breast after the breast cancer resection. So in the same way, depending on the degree of the ptosis, the excess of skin, you will perform a round blood technique or an inverted T mammaplasty, depending on the patient, depending on the aesthetic indication of breast lifting. But the more difficult situation is this patient with small breast, no excess of gland, no excess of skin. And for this patient, there's no possibility to do the breast remodeling just by using the gland. You need to find something else, something outside from the breast, and this is a replacement technique. So we will use some local flaps, we will harvest some tissue from outside of the breast to fill the defect due to the breast cancer resection. And in this area of the chest, the vascularization can provide many options in terms of perforator flaps, so you can harvest some tissue coming from some vascularized by some perforating vessels from the intercostal pedicule or the thoracodorsal pedicule. So there's many options that you can use to fill this defect. So you can for sure use the TDAP flaps. This is a perforator flap based on the vascularization of the latissimus dorsi muscle, but you can also harvest some local perforator flaps based on the lateral thoracic artery or based on the intercostal perforator. And this is something that is quite new for us, and it helps us to increase the indication of
Recording stopped.
breast-conserving surgery, even for this patient with small breast. The planification of this surgery is based on the ultrasound. So before surgery, we perform a mapping of the area just for looking for the main perforators. During surgery, we dissect these small perforators, and depending on the size of these perforators, we can harvest 1 or 2 perforators. Just to confirm the good viability of this local flap, we use fluorescence imaging. So we inject indocyanine green in the general circulation, and with this probe, we can assess that the flap is well perfused. Then we perform the desepithelialization of the flap, and the flap is twisted to fill the defect of the breast. At the end, you see it's like a normal breast. You just have the scar on the lateral part of the chest, and there's no changement in terms of breast shape if you compare before and after the surgery. This is the same volume, the same degree of ptosis, and for the patient, in terms of sequelae, this is the best option.
We need to stop you for 10 seconds because of a synchronization issue, and then we will restart. We apologize for that, but with the 2 parallel streamings, Zoom and YouTube, right? So we stopped.
The Zoom session crashed, but you were present on the streaming.
Okay.
No, people can hear you, but they cannot see your slides, so they just told us that they would like to see what you are
Okay.
displaying. So that's why we just stopped, because we have approximately the same audience on Zoom and YouTube that we have here in the room, so we have to take it into account.
So, you know, we have a new, it's a novel way. Usually people take breaks between talks, but we now create a new system where we take a break during the talk. I mean, that's a new, it's a new system. We apologize for that, but we want to synchronize what they see with what they hear.
Do you want me to launch again the presentation, or it's fine? No? Yeah.
No, but should he?
Launch your presentation again. To be honest, I'm just moderating. I'm not a technician. Technical manager.
Il doit recommencer là.
Si vous nous suivez sur Zoom et sur YouTube, on essaie de trouver une solution pour que tout le monde puisse voir les slides que nous avons la chance de voir ici dans la salle. Je pense que c'est une question d'ordinateur, effectivement. Désolée de vous avoir interrompu, professeur, mais je pense que le temps qu'il trouve une solution, ça risque de prendre du temps, oui.
We can restart. Apologies.
So for this patient, it was a perfect indication for a lateral intercostal perforator flap, just because the goal was not to change the shape of the breast. We wanted to keep the same degree of ptosis and the same volume. Another patient with a small breast, no excess of gland, no excess of skin. So in the same way, we harvested a lateral intercostal perforator flap to fill the defect due to the breast cancer surgery. And at the end, again, there's no deformity of the breast and no sequelae for the patient. Another indication for this local perforator flaps. So this patient had breast cancer involving the neck, so we did neck resection, and we used the skin from the chest to reconstruct the skin of the neck resection. And the perforating vessels was coming from the anterior part of the intercostal pedicle, so this is why it is an anterior intercostal perforator flap. And we have also the possibility to use these local perforator flaps to correct aesthetic sequelae after breast-conserving surgeries. And it was another indication of these local flaps. You see this patient didn't have any oncoplastic surgery, and she had a huge retraction of the breast on the upper and lateral quadrant. But at the end, for all these patients, you can feel that we are on the limits of the breast-conserving surgeries. So for this patient, there's probably a good indication of immediate reconstruction. And we know how to perform this immediate reconstruction properly. We know how to achieve breast symmetry, aesthetic breast. So we know how to make it, and we know how to make it even in case of adjuvant treatment. The thing is that in our consultation, most of the patients that we are seeing are patients who are demanding for delayed breast reconstruction. And if you look to the history of this patient, you will see that most of these patients didn't have any immediate reconstruction just because of the necessity of radiation therapy. And that's a pity because we know now how to perform an immediate reconstruction in case of adjuvant radiation therapy. So if we want to change the reality of breast reconstruction, we need to change the mind of the surgeons and the medical oncologists to convince them that it is possible to offer immediate reconstruction even in case of adjuvant treatment. And in France, the rate of immediate reconstruction is quite low. It's about 15%. So there's some difference between the region, between the hospital, public or private hospital. But at the end, this rate is quite low, too low. And again, we have to do the maximum to change this reality. And we know now, because of the data, that we have the same rates of recurrence or survival for this patient who have immediate reconstruction compared to delayed reconstruction. There's no delay in diagnosis of local recurrence in case of immediate reconstruction, and there's no impact on the quality of the adjuvant treatment. So immediate reconstruction is feasible, and we have to offer it for the patient who are demanding for reconstruction. And we know now that it's also possible to spare the nipple. The classical indication is for patients who have lesions that are more than 1 centimeter from the nipple, with no nipple discharge, no Paget disease, and most important, after surgery, you need to assess the quality of the margin, so you need to have clear nipple margin on the specimen. So at the end, the last contraindication for an immediate reconstruction is T4D disease, inflammatory breast cancer, but radiation therapy or chemotherapy are not anymore a contraindication for an immediate reconstruction. So what will be the impact of this adjuvant treatment on the reconstruction? If you consider only radiation therapy, we know that it will increase the risk of complication, it will increase the risk of failure of reconstruction with lower satisfaction for the patient, bad aesthetic results, and the rate of capsular contracture is up to 40%. So we know that with radiation therapy, unfortunately, the quality of the reconstruction will be decreased by the treatment. For the chemotherapy, we don't have any impact on the quality of the reconstruction. We have the same rate of complications, the same rate of failure. So if we consider just radiation therapy, you will see, depending on the technique of the reconstruction, we don't have the same sequelae. If you use a flap, pedicle flap like a latissimus dorsi or free flap like a Dieppe flap, the consequences are very severe because they are definitive. If you have a complete atrophy of the latissimus dorsi muscle after radiation therapy, you need to consider a second flap, a free flap. If you have severe cytostatonecrosis after a Dieppe flap, you need to do fat grafting, tissue resection, so it's very difficult. The problem is that these techniques are definitive, so we want to avoid this definitive sequelae on the flaps. If you have some issue with the implant, there are still many options to fix this problem. You can convert the implant for a flap, like a LD flap or a free flap. You can use fat grafting, you can make implant revision. So at the end, with an implant, there are still many options to fix and to correct the sequelae. So this is our strategy. When a patient is demanding for an immediate reconstruction, even if she's demanding for an autologous reconstruction, because of the need of adjuvant treatment, potentially radiation therapy, we prefer to use the implant as a spacer just to spare the skin, to spare the tissue, and to wait for the end of the treatment. So we perform the reconstruction with the definitive implant, and the patient receives the chemotherapy, the radiation therapy, and few months after the end of the radiation therapy, between 6 to 8 months, we discuss with the patient about how we can finalize the reconstruction. Can we keep the implant? She's happy with the implant, so we can make some small revisions. Or is she still demanding for an autologous reconstruction? And then we will convert the implant for a free flap. So by this way, we consider that we can limit the risk of definitive sequelae for the patient, and we can offer the option of immediate reconstruction to the maximum number of patients. And to do that, it's very important to work very closely with the radiation therapy, the medical oncologist. It's a teamwork. So if we want to change the mind of the physicians, we need to work very closely with them. We need to sit and to discuss with the radiation therapists of the options of the treatment. If the patient had already some radiation therapy because of a local recurrence or, for example, a Hodgkin disease, we cannot offer safely the option of an implant because of the high risk of immediate complication or late complication like capsular contracture. So at the end, our algorithm for immediate reconstruction is quite simple. If there's no adjuvant radiation therapy, we can offer implants or flaps, depending on the morphology of the patient, depending on the expectations of the patients. And if radiation therapy is expected, we go for an implant that we use as a spacer. And if the patient had already received some radiation therapy, we go directly for a flap. And this is possible because we try as much as possible to offer safe surgical technique to limit at the maximum the risk of complications. And if the patient has a complication, we need to treat it very quickly, in less than 1 month, just because we keep in mind that we mustn't delay the adjuvant treatment. So you understood that implant is our first choice when radiation therapy is expected. So for this patient, most of the time the aesthetic results are quite good, but quite good on the surgical point of view. For the patient, when we put some implant below a muscle, they are suffering a lot about breast animation. And breast animation is a severe sequelae for the patient, not only an aesthetic sequelae, but mainly a functional sequelae with a huge impact on the quality of life. They are complaining about the animation, the tightness of the breast, and sometimes of the pain. And because we know that if we convert from retropectoral to prepectoral pockets, these implants, we change completely the quality of the life of the patient. They are quite happy, even if the implant is more visible. So at the end, the question is, why do we still use the muscle to cover the implant? Is it for coverage? Probably not, because we have now the possibility to use fat grafting, so we can sometimes reconstruct a whole breast just with fat grafting, so pectoralis major muscle is not necessary to obtain this coverage. Do we use this muscle to give a support for the implant? Probably not, because now we have some devices like meshes or ADM to give this support. And does this muscle give a protection to the implant to cover the implant because of the risk of secondary exposure? Now we know how to perform a safe mastectomy. We can limit the risk of skin necrosis, so no, at the end it doesn't give a protection. So this is why now we use for more than 95% of our patients prepectoral reconstruction in case of implant. Because again, we are obsessed by the goal of limiting the sequelae for the patient. We don't want to give to create some functional impairment for the patient. And there's also many other benefits. First, you can shorter your operating time. The patient is painless, so you can have a diminution of the narcotic use. The patient feel a better mobility of the chest and of the arm, with less need of the physical therapy. And at the end, you can decrease the length of hospital stay. So many advantages for the patient and for the surgeon. And something that we didn't expect it from the beginning is that you will have also an impact on the risk of capsular contracture. If you compare patient with prepectoral implant and retropectoral implant, in case of adjuvant radiation therapy, you will see first same rate of complication, but most important, lower risk of capsular contracture and severe capsular contracture. So the prepectoral positioning of the implant can probably reduce this rate of capsular contracture. We don't have a lot of data about that, but the first publications are very encouraging. So how can we make this prepectoral reconstruction? Like always in surgery, first we need to select properly the patient. So we try as much as possible not to perform this for patients who are smokers with an obesity over 35. So it's not absolutely a contraindication, but it's a risk factor. So if you have the association of different risk factors, you need to consider another option of reconstruction. The second point is the quality of the mastectomy. So this is the key for breast reconstruction. So in Gustave Roussy, we use the tumescent infiltration. So the idea is to infiltrate between the gland and the dermis some saline with epinephrine. So by this way, we create an hydrodissection and vasoconstriction of the vessels. And we can perform properly the mastectomy just with the scissors. So it's like lifting. We just have to follow the plane of the hydrodissection. So there's less risk of thermal injury of the skin and no risk of mechanical injury because you don't have to use retractors for the superficial part of the dissection. And at the end, you just have to detach the gland from the chest wall. So it's quite fast and first of all, it's safer for the skin envelope and the risk of skin necrosis. Third point is that we use for most of the patients silicone implant. We don't use any more expanders. First, because of the patient, we want to avoid for this patient the necessity of several reinflation of the expander. We prefer to use the definitive implant from the first stage. And there's also some advantages in terms of quality of radiation therapy. If you have to the radiation therapist, if he prefers to do the radiation therapy on an implant or expander, most of them prefer to do it on an implant because there's no the metallic port of the expander and no risk of reduction of the doses below the metallic port of the expander. And in terms of tissue coverage, because the volume of the implant is definitive, you don't have this plicature of the expander and the risk of secondary exposure of the expander at the level of the plicature. So to maintain the implant on the right place, we use these devices, meshes or ADMs. So it's a mesh that we can use to cover only the anterior part of the implant. So we fix the mesh at the level of the clavicula, then on the inferior fold to close the pocket and to maintain the implant. or we can also use the Ravioli technique. So the idea is to prepare on the table the implant completely covered by the mesh. So one surgeon is performing the mastectomy, and at the same time, the other surgeon is preparing the implant. So it's a huge gain of time for the patient, and we can shorten the duration of the surgery. After that, when you have prepared your ravioli, you just have to reattach it on the chest wall with few stitches to maintain the implant on the right place. But you notice that the implant is just below the skin. It means that you will have a visibility of the contour of the implant. So for all these patients, if they decide to keep the implant, we perform 1 or 2 sessions of fat grafting to avoid the visibility of the contour, to reduce the rippling effect, and at the end, to improve the quality of the long-term result. So again, for all these patients who are demanding for immediate reconstruction, if there's a doubt on the radiation therapy, or if radiation therapy is expected, we go for prepectoral implant. We use it as a spacer in case of nipple sparing or in case of skin sparing mastectomies. And for some patients, even in case of radiation therapy, the capsular contracture is not so important, so we can keep the implant. We just perform a few sessions of fat grafting. And if you have a capsular contracture, it's not the end of the reconstruction. You just have to convert your implant to an autologous reconstruction. So we remove the prepectoral implant and we replace the implant by a flap, a pedicle flap or a free flap, depending on the demand of the patient. So a few years ago, the options of reconstruction were quite limited: retropectoral implant or expander, some cases of fat grafting, tram flap or latissimus dorsi. But again, because of the improvement of the technique of the surgery, because of the advances of technology, we are not able to offer more options in terms of quality of reconstruction. And first of all, we can reduce the morbidity for the patient and we improve the quality of their life. So for us, the 3 main evolution of breast reconstruction during the last 5 years were the use of local perforator flaps in Oncoplastic Technique that can permit us to offer breast conserving surgery even for patients with small breast size, the possibility to offer immediate reconstruction even in case of adjuvant radiation therapy, and the possibility to perform prepectoral reconstruction safely with definitive implant. Thank you for your attention.
Thank you very much for a very clear and interesting lecture. Can I ask for questions from the audience? Professor Casimir.
Thank you for your lecture. I have a question about the material, the artificial material you use. Do you observe some contact allergic reaction or rejection of this artificial material or prosthesis you use?
A few years ago, we started to perform this surgery by using some ADMs. And for these devices, we had some cases of red breast syndrome. It's like allergy due to the material. But now we are using more some synthetic absorbable meshes. There's no...
So, yes, we're going to have a break of 15 minutes. So, let's get back here at 10:30 so that we can solve the problem. Si vous êtes sur Zoom ou sur YouTube et que vous nous suivez, vous risquez d'être déconnecté. Donc, reconnectez-vous, s'il vous plaît, dans 10 minutes, afin que vous puissiez, vous aussi, bénéficier des PowerPoint qui sont... présenté par les orateurs. On va demander au professeur Leymarie de partager ces slides avec nous s'il accepte pour que nous puissions vous les transmettre. Voilà, à tout à l'heure, 10h30, rendez-vous sur Internet et dans la salle.
Je ferai une vidéo, je vais tout mélanger pour l'enregistrement. D'accord, ok. Vous aviez le son de faire déjà. Je sais pourquoi je prends tout ça. Non, il y a des branches. J'ai l'impression, et là maintenant on va de nouveau. J'espère qu'on va le garder. Mais c'est sûr, mais après, pourquoi est-ce qu'on avait l'image? Ça dépend quel type de prothèse. On a récupéré l'image ici. On va voir maintenant si on récupère l'image.
Recording in progress.
Welcome back to the session. We took an early break, so now we go forward, full speed. The plane will take off. The engine's really, really high now. So it's a great pleasure to introduce the next speaker, Professor David Pasquier from University of Lille. He is an associate professor at the University of Lille in the Department of Radiotherapy, Centre Lambret. He has obtained in 2017 the habilitation to conduct high-level research and to guide the PhD and advanced thesis. He is a praticien hospitalier spécialiste des centres de lutte contre le cancer, chef de clinique assistant between 2002 and 2005. He is president of the Bureau of Translational Research at the University of Lille, Centre Lambret, and he has done research and a lot of activity in this area, and he is in the Department of Precision Medicine. He was trained and did some research in the Department of Precision Medicine at the Maastricht University Center, and then also at the radiotherapy department of our own hospital, Saint-Luc in Brussels. He will present his lecture in French, but will have the slides in English. So in this way, I think we will be multilingual. Thank you for your presence.
Yeah, I have a quite long talk, so I will switch to French. I'm afraid to don't be on time. Okay, so, merci pour votre invitation. Nous allons donc parler de l'irradiation du cancer du sein, qui est bien sûr un très ancien traitement, avec peut-être les premiers traitements à la toute fin du 19e siècle. Alors les continents se disputent, vous le savez, la paternité de la première patiente traitée, ça n'a aucune importance, mais on a vu apparaître les premiers référentiels de prise en charge, en tous les cas au tout début du XXe siècle. Et puis on ne peut pas faire autrement que de montrer cet autoportrait de notre collègue français, alors qui était peintre d'abord, qui a fait les beaux-arts, avant de se lancer dans des études médicales, dont on devine qu'elles étaient sûrement un peu plus simples, un peu plus courtes à l'époque qu'elles ne le sont maintenant. Alors, si on s'intéresse bien sûr à l'irradiation, c'est le standard après une chirurgie du sein, une chirurgie en tout cas qui conserve le sein sur la foi de ces données qui sont anciennes, alors qui sont très connues, mais qu'on doit montrer néanmoins. On voit que cette irradiation en post-opératoire après une chirurgie qui conserve le sein permet de baisser de façon très nette le risque de récidive et permet également un gain en survie globale. Si on s'intéresse uniquement à droite aux patientes qui sont PN0, on voit encore qu'on diminue de beaucoup, de plus de moitié, ce risque de récidive locale et on conserve là encore un gain en survie globale de l'ordre de 3%. Si l'on reste quelques secondes encore sur ces bases un peu anciennes, mais c'est important, on voit ici le bénéfice en termes de survie sans récidive de l'irradiation chez ces patientes. Encore une fois, des patientes traitées dans les années 80 et 90, donc pas les patientes que l'on traite actuellement, mais on voit le bénéfice de cette irradiation en fonction de l'âge, de la taille, PT1 ou PT2, et du grade. Et on devine d'ores et déjà, sur ces données anciennes, qu'il existe un groupe de patients pour lesquels, sans doute, on peut alléger les traitements, voire ne pas traiter ces patientes. On l'a dit, les patientes que l'on traite ne sont plus les patientes de ces essais. Avec le dépistage, les stades sont beaucoup plus précoces qu'ils ne l'étaient dans ces années passées. Et puis, les améliorations dans la chirurgie, dans les traitements systémiques, ont très sûrement fait baisser le risque de récidive en comparaison de ces données. La radiothérapie est associée, on l'a vu, à deux types de complications. Tout d'abord, la fibrose, qui se traduit sur un plan esthétique, sur un plan cosmétique, pour reprendre un peu le terme anglais, avec des résultats ici, en post-opératoire en haut, et puis des résultats plutôt bons pour la patiente qui est à gauche, plutôt moyens, avec là une fibrose à 2 ans, avec une ascension du sein, et puis un résultat plutôt mauvais à 2 ans pour la 3e patiente. C'était l'essai qui évaluait le boost, j'en parle dans quelques minutes. L'autre grand item, bien sûr, en particulier pour les patientes qui sont irradiées pour le sein gauche, ce sont les complications cardiaques. Alors, avec les données de Darby et de Taylor, qui elles aussi sont discutables parce que basées sur des données qui sont anciennes, des patientes traitées dans les années 60, et on a ici sur cette courbe eh bien, le risque relatif de complications cardiaques en fonction de la dose moyenne au niveau du cœur. Je voulais prendre 3 à 4 minutes pour vous présenter les progrès techniques et technologiques de nos traitements qui ont contribué en quelque sorte à alléger l'ensemble de nos traitements, quelles que soient les patientes, quels que soient les volumes que l'on traite. Alors nous sommes passés des techniques des années 90 à 2000, alors tout ça n'est pas bien sûr binaire, à l'implémentation de l'imagerie et du scanner dans la préparation de nos traitements. Donc avec le scanner, dans les temps un peu plus anciens, mais pas si anciens que ça, la préparation se faisait d'après des repères osseux ou même à la peau de la patiente. Et donc, on avait une connaissance assez approximative des doses que l'on donnait chez nos patientes. Cette préparation avec le scanner nous permet donc de définir coupe par coupe pour chaque patiente les volumes que l'on veut traiter et les volumes que l'on souhaite épargner le plus possible, bien sûr le cœur et les poumons. Avec ces référentiels de contourage, on voit que ce n'est pas si vieux que ça. Ici, donc, vous avez le référentiel de 2015 de l'Estro et puis un référentiel un peu plus récent de 2019 chez les patientes dont on a parlé, qui bénéficient d'une chirurgie de reconstruction immédiate, le but étant de tenter, là encore, de baisser le risque de fibrose chez ces patientes. Donc tout ça n'est pas si lointain. Autre progrès, la modulation de l'intensité qui a pour but premier, dans le cancer du sein, de rendre la dose la plus homogène possible dans le sein. Ce n'est pas le cas pour d'autres cancers, mais vraiment là, on souhaite avoir la dose la plus homogène dans le sein pour pouvoir éviter ces surdosages que l'on avait dans le temps dans le sillon sous-mammaire. Des essais randomisés ont montré un bénéfice pour cette technique. Ce sont des essais un peu anciens déjà, avec des bénéfices en termes de complications à court terme, mais aussi un bénéfice en termes de complications sur le très long terme, en particulier sur les changements esthétiques et sur la diminution de volume du sein. Autre avantage de cette technique, ce n'est pas le premier avantage, mais cette technique permet également de baisser les doses les plus importantes, les plus élevées. Ne baisse pas la dose moyenne, mais baisse les doses les plus élevées, en particulier sur la coronaire antérieure, qui est peut-être un marqueur un peu plus pertinent que la dose moyenne cardiaque. Si l'on s'intéresse à la préservation du cœur, il faut aller plutôt vers des techniques d'inspiration profonde qui permettent bien sûr de pouvoir éloigner le cœur de la zone que l'on va traiter. On voit sur ce papier qui a été publié en 2019 que cette technique permet donc de baisser la dose moyenne de l'ordre de 35%, y compris chez des patientes que l'on traite sur tous les volumes. Il existe à peu près une quinzaine d'études de comparaison des deux techniques, et cette baisse de la dose moyenne est plutôt de l'ordre de 50%, et elle est du même ordre pour la diminution de la dose à la coronaire antérieure. Alors ces techniques, quand elles sont apparues, étaient un peu compliquées. On voit ici à gauche une patiente qui respire dans un spiromètre avec un pince-nez, un retour vidéo de ses cycles respiratoires dans des lunettes. C'était un peu anxiogène, assez compliqué. Les patientes devaient suivre un entraînement, ça prenait du temps. Et donc, de façon plus simple, ces techniques sont maintenant associées à des techniques qui repèrent la surface de la patiente avec des nappes de laser qui permettent donc de suivre en temps réel le mouvement de la patiente et s'assurer que cette irradiation ne se fait bien que dans les temps d'inspiration profonde bloqués chez nos patientes. Cette frise reprend les progrès donc, qui ont permis, encore une fois, d'alléger les séquelles de nos traitements. Nous sommes passés de techniques des années 90-2000 sans imagerie, on l'a dit, avec une connaissance quasiment nulle ou très faible des doses que l'on délivrait dans nos patientes, donc y compris au niveau du sein. L'intégration du scanner dans les années 2000 à 2010 avec des doses moyennes cardiaques plus faibles de l'ordre de 1 à 3 Gray, pour le sein gauche bien sûr, et l'implémentation de la modulation de l'intensité et de l'inspiration profonde, si bien que nos patientes maintenant, à l'heure actuelle, traitées pour un sein gauche, ont toutes ou quasiment toutes des doses moyennes inférieures à 1 Gray. pour poursuivre, alors, si l'on veut maintenant alléger nos traitements, on peut jouer sur 3 leviers. Le nombre de séances, le volume, ne traiter qu'une partie du sein, et la dose. On traite ou on ne traite pas. Si on parle du nombre de séances, de la même façon, on ne peut pas ne pas montrer les travaux de nos collègues anglais qui sont très actifs sur le sujet, avec les fameux essais START A et START B, qui ont fait de ce schéma, en 15 séances, un standard actuel. Alors, ce n'est pas si ancien que ça, il faut toujours du temps pour s'approprier ces standards. Et ce schéma, en 15 fractions, a en plus un bénéfice en termes de complications tardives. On le voit sur ce graphe-là. Si on le compare au schéma qui était le standard de 50 degrés en 25 séances, eh bien on voit moins de diminution de volume mammaire, moins d'induration et moins de complications au niveau de la peau. Donc ce schéma, en 15 fractions, est le standard actuel chez les patientes de tout âge. Nos collègues sont allés plus loin, alors un très grand pas plus loin. On ne pensait pas, pour être franc, aller jusque-là dans la décroissance du nombre de séances si on parle toujours de l'irradiation de l'ensemble du sein. Et donc, dans cet essai, nos collègues ont comparé ce schéma en 15 fractions à 2 schémas en 5 fractions sur l'ensemble du sein, donc 2 schémas de 26 et de 27 degrés. C'est là encore un très grand essai avec plus de 4000 patientes. On voit néanmoins que la taille médiane est faible de 1,6 cm avec des tailles qui sont quasiment maximales de 2,2 cm. Les patientes pouvaient avoir eu un traitement par chimiothérapie. Un quart des patientes avaient un boost au niveau du site opératoire. Les résultats sont connus maintenant. Voilà. Avec un suivi médian de l'ordre de 6 ans, eh bien, il n'y a pas de différence en termes de contrôle local de la maladie. Nous sommes à moins de 3% à 7 ans pour l'ensemble de ces schémas et peut-être même une tendance plutôt favorable pour les schémas en 5 séances. Mais par contre, un peu plus de complications locales dans le groupe des patientes traitées en 5 séances avec la dose la plus élevée de 27 degrés. Alors c'est une évaluation qui est faite par les médecins. On peut avoir toujours quelques petits doutes, mais bon. Mais si on s'intéresse aux évaluations sur photo, quand les médecins ne savent pas quelle est la dose qui a été donnée, on voit là encore plus de changements d'aspect du sein dans le groupe de 27 degrés comparé au groupe de 40 degrés. Ce n'est pas le cas avec le schéma de 26 degrés en 5 séances qui est maintenant maintenant implémenté dans nos services. On va voir pour quelle patiente dans quelques minutes. On peut jouer donc également sur le volume. On passe d'une irradiation de l'ensemble du sein à une irradiation partielle du sein. 2 essais sont publiés. Ils sont connus, donc là encore, un essai qui est nord-américain avec des critères d'inclusion peut-être un peu trop laxistes, on ne sait pas, jusqu'à 3N+, si bien que dans cet essai, environ 10 à 11% des patientes étaient PN+. Le but premier était encore le contrôle local au niveau du sein. Les critères de l'équivalence n'étaient pas respectés, ils étaient sans doute un peu stricts. On voit une surincidence de la récidive locale au niveau du sein en défaveur de cette irradiation partielle du sein, mais cet écart est très faible. Et puis, une alerte qui est plus embêtante à mon sens, dans cet essai rapide, c'est le même schéma de 38 degrés en 10 séances sur 5 jours, 2 séances par jour. Pas forcément très simple à mettre en œuvre, mais ça c'est plus embêtant parce qu'on voit dans cet essai plus de complications tardives au niveau du sein, en particulier en termes de fibrose, de complications esthétiques, de complications au niveau de la peau. Et encore plus embêtant, parce que c'est le plus important, c'est bien sûr de demander l'avis des patientes, ce n'est pas l'avis du médecin qui est le plus important. Si on demande ici l'avis des patientes, alors ma souris n'est pas là, mais ce n'est pas très grave, donc c'est là. Si on demande l'avis des patientes, eh bien 2 fois plus de patientes estiment que le résultat esthétique est pas bon ou pauvre après ce type de traitement très partiel et très rapide. Toujours dans le cadre d'une irradiation partielle, un schéma qui est plus simple à mettre en œuvre, encore nos collègues anglais qui ont comparé le schéma A à une irradiation partielle, c'est le bras C, qu'on ne voit pas très bien ici, mais avec des critères d'inclusion qui sont très proches. de ceux que l'on vient de voir, un suivi médian de l'ordre de 5 ans. Là encore, pas de différence en termes de survie sans récidive locale, pas d'écart en tout cas en termes de survie sans récidive intramammaire, et un bénéfice, c'est intéressant, un bénéfice en termes de complications locales, moins de changements d'apparence du sein en faveur de cette irradiation partielle, moins d'induration du sein, là encore, en faveur de ce schéma, en 15 fractions sur 3 semaines dans le cadre de cette irradiation qui est donc partielle. Il existe d'autres techniques pour les irradiations partielles du sein, alors qui sont moins répandues, bien sûr, ces irradiations intraopératoires. On peut passer assez rapidement sur le premier essai, Elliott, qui employait des électrons. C'est un essai qui est clairement négatif, avec une surincidence très nette des récidives locales en défaveur de cette irradiation partielle du sein. Et le second essai, qui est Target, qui est un essai très controversé, qui fait couler beaucoup d'encre à chaque nouveau papier. On voit alors une discrète surincidence des récidives dans le groupe de l'irradiation partielle, mais l'hypothèse statistique était un peu lâche peut-être, on ne sait pas. C'est un essai qui est en tout cas très controversé. La curéthérapie, qui permet également donc une irradiation partielle du sein avec les deux principaux essais randomisés. Le premier, le plus ancien, je vous le montre parce que la mise à jour a été faite il y a juste quelques mois avec un suivi médian de l'ordre de 15 ans et plus. Alors c'est un peu moins que ces 16 ans et quelques mois, mais un très long suivi. Alors ces deux essais randomisés nous montrent quoi? Nous montrent que le taux de contrôle local est très bon, pas plus de récidive intramammaire après curéthérapie, donc du sein, bien sûr, au niveau du foyer opératoire, en comparaison avec une irradiation de l'ensemble du sein, et un bénéfice sur le plan esthétique qui n'est retrouvé par contre que dans le premier essai et pas dans l'essai du Jacques-Estro. Pas de bénéfice sur le plan esthétique en comparaison avec des irradiations partielles, en tout cas de 50 degrés en 25 fractions. Et puis le troisième levier sur lequel on peut jouer, c'est la dose. On traite ou on ne traite pas, donc en tout cas on baisse la dose physique. Si l'on revient aux indications d'irradiation de l'ensemble du sein, on a parlé il y a quelques minutes de complément de dose, donc de boost, que l'on donne au niveau du site opératoire. Alors on fait ça sur la foi de cet essai en particulier, il y a 2 ou 3 essais, mais je crois que celui-là est le plus démonstratif, c'est l'essai de l'ERTC qui montre un bénéfice en termes de contrôle local avec ce complément de dose. Ce bénéfice persiste toute la vie de la patiente, près de 20 ans après le traitement local, et on voit qu'il est d'autant plus important que la patiente est jeune à l'âge où elle est traitée. On voit ici donc ces écarts de contrôle locaux, en tout cas de survie sans récidive mammaire, en fonction de l'âge de la patiente. Mais par contre, comme souvent, cette augmentation de dose a un coût en termes de complications locales et a un coût en particulier sur le plan esthétique, même si les techniques de l'époque sont tout à fait obsolètes par rapport à celles que l'on emploie maintenant. Donc, il est maintenant acquis, on est passé d'une prescription peut-être quasiment automatique de ce complément de dose à une prescription plus adaptée au risque de la patiente, et il est maintenant acquis dans tous les référentiels que les patientes les moins à risque de récidive peuvent ne pas avoir de boost. Il s'agit en particulier des patientes de plus de 50 à 60 ans, ça dépend des référentiels, avec des tumeurs de faible grade et de petite taille. Un pas plus loin, encore une fois, peut-on ne pas traiter les patientes? Peut-on ne pas les irradier? La réponse est sûrement oui. Il faut s'intéresser là plutôt aux essais les plus récents. Je montre à nouveau les données plus anciennes de l'EBC-TCG. Il faut s'intéresser aux essais randomisés les plus récents. On va faire un focus sur 2 de ces essais. Le premier, c'est PRIME, qui incluait des patientes de plus de 65 ans avec des tumeurs de 3 cm, plutôt de grade 1 à 2, donc les patientes étaient irradiées ou pas. Et on retrouve, alors ce que l'on savait déjà, ce taux de récidive mammaire de l'ordre de 10% à 10 ans chez les patientes qui ne sont pas irradiées. Bien sûr, il n'y a pas de différence en termes de survie globale. L'irradiation mammaire n'impacte pas, n'améliore pas la survie globale chez ces patientes qui ont un pronostic très bon. Autre essai qui est plus ancien mais qui est intéressant puisqu'il faut se poser la question aussi de l'omission de tous les traitements adjuvants, pas que de l'irradiation. Et là, c'est un essai à 4 bras. C'est un essai qui est intéressant parce qu'il concerne également des patientes jeunes. On voit que l'âge médian dans cet essai est de 57 ans, donc c'est l'âge médian du cancer du sein dans nos contrées. Il s'agissait de patientes avec des tumeurs de moins de 2 cm, de grade 1 ou en tout cas de bon pronostic, et elles étaient donc randomisées entre pas de traitement adjuvant en post-opératoire, une irradiation de l'ensemble du sein, le tamoxifène seul ou les deux. Et avec un suivi médian de 10 ans, eh bien, on retrouve les données que l'on vient de voir, en tout cas proches. Le taux de récidive à 10 ans est de l'ordre de 22% sans traitement complémentaire, de 8 à 10% avec l'un ou l'autre de ces deux traitements et de 2% si on combine les deux. Donc cette omission de l'irradiation est maintenant dans les référentiels, en particulier pour les patientes à faible risque de récidive, dont la définition est à peu près consensuelle, même si elle est peut-être un peu frustre, à savoir les patientes les plus âgées, avec des tumeurs qui expriment les récepteurs aux hormones CN0 et PT1. Une remarque quand même, on peut estimer que la compliance de l'hormonothérapie dans les essais randomisés est bien meilleure qu'elle ne l'est dans la vie réelle. Donc on peut se poser la question de la surveillance et de la compliance de l'hormonothérapie chez des patientes qui ne seraient pas irradiées. Des essais en cours ont pour but de pouvoir préciser ce choix avec des biomarqueurs qui sont connus, que je ne vais pas donc citer, mais qui sont connus. Et puis, un item qui n'a pas été assez évalué dans ces essais un peu anciens, c'est la qualité de vie de ces patientes. Elles ont un pronostic très bon, donc il s'agit de ne pas les surtraiter. On peut omettre, pourquoi pas, 1 ou 2 traitements, il faut savoir lequel. On va le voir, il faut leur poser la question. Et je trouve que cet essai qui est en cours, qui est très intéressant, c'est une phase 3 qui s'intéresse aux patientes dont le pronostic est très bon, de plus de 70 ans, avec des tumeurs de petite taille, avec une tumeur qui exprime les récepteurs aux hormones. Et dans cet essai est donc randomisée une irradiation partielle du sein à une hormonothérapie. Le principal objectif, c'est plus la survie sans récidive, puisqu'on sait que c'est très très proche et que c'est plutôt bon, mais c'est la qualité de vie. Et ça, c'est vraiment très très important. En conclusion, on l'a vu, la technique a permis d'alléger l'ensemble de nos traitements. Si on s'intéresse à l'irradiation de l'ensemble du sein, le standard, c'est 15 séances. Là, il n'y a plus de doute, c'est 15 séances. Ce schéma, en 5 séances, par contre, bon, c'est un peu plus incertain. Est-ce qu'il faut l'appliquer à toutes les patientes ou à la majorité de nos patientes? Vous voyez, ça fait l'objet de débats à l'Estro l'année dernière. Il va encore y avoir une journée, enfin, pas une journée, mais une session spéciale à l'Estro qui commence là, qui commence aujourd'hui. C'est encore un peu incertain, mais on peut, sans crainte aucune, vraiment implémenter ces schémas en 5 séances sur l'ensemble du sein, en tout cas chez les patientes les plus à faible risque. Chez les patientes, pour le dire plus simplement, les patientes les moins à risque de récidive. Un consensus de l'Estro a été publié en 2022. On devine que le consensus n'a pas été simple à obtenir puisque le consensus, c'est ça peut être un standard ou ça peut être une étude clinique ou un registre. Bon, en tout cas, on peut le faire sans risque aucun chez les patientes à faible risque. Si l'on s'intéresse à l'irradiation partielle, il faut se rapprocher des référentiels de l'Estro et des référentiels du NCCN qui sont les mêmes, qui sont vraiment symétriques. Il s'agit de patientes de plus de 50 ans avec des tumeurs de moins de 2 à 3 cm, avec des berges saines, qui expriment les récepteurs aux hormones, plutôt de grade 1 à 2 et sans embol vasculaire, avec, je crois que c'est plutôt pas mal, des tumeurs unicentriques pour le référentiel de l'Estro, qui conseille aussi les schémas, à savoir des schémas en 15 séances ou en 5 séances. Pas le schéma en 10 séances sur 5 jours. Pour terminer, chez ces patientes à faible risque de récidive, la sélection du traitement ou de l'absence de traitement doit se faire bien sûr sur ce risque de récidive, sur la balance avantage-inconvénient des traitements qu'on peut leur proposer, plus ou moins courts, plus ou moins complexes, la qualité de vie qui n'a pas, à mon sens, été et je pense évalué assez finement dans ces essais un peu anciens, mais des essais sont en cours, des biomarqueurs sont en cours d'évaluation pour tenter de nous aider à préciser ces choix. Et puis, il faut informer, bien sûr, les patientes de la façon la plus complète qui soit pour qu'elles puissent prendre part à ce choix ou au choix du traitement, au choix du schéma, ou même à l'absence de traitement après leur mastectomie. Merci à vous.
Merci beaucoup. Des questions dans la salle. Professeur.
Merci beaucoup pour votre exposé. Question de quelqu'un qui connaît mal le problème, mais est-ce que la protonthérapie a une place dans ce traitement? Parce que quand on voit chez les enfants la possibilité de frapper de manière très ponctuelle, c'est évidemment quelque chose qui paraît être important.
C'est une très bonne question. Alors, c'est une question un peu préliminaire, on n'a pas de réponse encore, effectivement. Votre question, pardon. Oui, c'est une très bonne question qui sous-tend bien sûr la protection des organes à risque, en particulier cardiaques. Je vais sans botter en touche, je pense qu'il faudra des essais cliniques, voilà, ou en tout cas des registres pour quantifier le bénéfice. On a vu que nos pratiques actuelles permettent quand même d'obtenir des doses cardiaques très très faibles, bien plus faibles que celles décrites dans les papiers qui sont à l'origine de ces courbes, de ces fameuses courbes dose moyenne, risque de complications cardiaques. On a quelques doutes sur la validité de ces données, mais il est possible que chez des patients, en tout cas les plus fragiles, sélectionnés, les protons puissent être un plus pour, alors là, optimiser vraiment complètement la protection cardiaque. Mais il faudra en passer par des registres, au moins par des registres, en tout cas par de la recherche clinique. Oui.
D'autres questions dans l'audience ici? Non. Alors, le milieu digital n'est pas prêt à poser de questions. On va offrir le volume de l'Académie par le secrétaire perpétuel.
Le cancer du sein HER2 positif est l'un des plus agressifs. Depuis l'introduction des thérapies ciblant le récepteur HER2, les chances de guérison se sont considérablement améliorées. Alors comment exploiter au mieux ces médicaments pour progressivement se passer de chimiothérapie? C'est un cheminement de 17 années que s'apprête à nous retracer la prochaine oratrice. Monsieur le Président, je vous laisse introduire ce membre de la compagnie.
Thank you very much. It's a great honor and pleasure to me to introduce Professor Martine Piccart, member of our Academy. She is a professor of oncology at the University Libre de Bruxelles and the scientific director of the Jules Bordet Institute in Brussels. She has been president of the European Cancer Organization, the European Organization for Research and Treatment of Cancer, EORTC, the European Society for Medical Oncology. She was on the board of ASCO, as well as on the board of the American Association for Cancer Research. And she was elected fellow of the AACR Academy in 2013. She is a leader in the field of cancer worldwide. She has catalyzed international research collaborations and most notably, together with Professor Aaron Goldhirsch, created the Breast International Group, BIG, 1996, which today unites 56 academic breast cancer research groups from all over the world. For this research advances and international activity, she received a number of prestigious international awards, and she authored 670 publications in peer-reviewed journals. So without further ado, thank you very much for your presence today.
Monsieur le Président, Monsieur le Secrétaire perpétuel, chers collègues, bonjour. And I'm going to switch to English. So my task today is to convince you that some patients with a particular breast cancer subtype that we call HER2 positive breast cancer will be cured one day with chemotherapy-free strategies. Here are my disclosures, so you can see that I'm consultant for several pharmaceutical companies. My institute receives research grants from many companies, in particular Roche, Genentech, which is a company that has developed most of the drugs that I will discuss today. The fascinating story I'm about to tell you starts in 1984 with the discovery of a new oncogene in the laboratory of Robert Weinberg in Boston. The encoded protein called HER2 belongs to the Rb family of growth factor receptors. There are in total 4 receptors, HER1, HER2, HER3, HER4. And these receptors play a central role in the pathogenesis of several cancers. Upon ligand binding, these receptors undergo dimerization and phosphorylation of their internal portion, the intracellular portion. The HER2-HER3 heterodimer is the one with the highest signaling potency. It activates many downstream pathways, in particular the Pi3k AKT pathway, which is a master regulator of cell cycle progression and cell survival. And then 3 years later, in 1987, an oncologist from UCLA decides to evaluate HER2 amplification in a series of frozen biobanked breast tumors. And he makes a critical observation. And this is that this genomic aberration is present in 1 out of 5 breast cancers and is associated with a very poor clinical outcome. So most of these women present a relapse and die from breast cancer within 3 to 5 years from diagnosis. And then a collaboration starts between UCLA and the company Genentech, and 5 years later, a humanized anti-HER2 monoclonal antibody is produced. It receives the name trastuzumab. It enters clinical investigation. And at the turn of the century, it is very clear that this drug is a real breakthrough and that it can improve, prolong the survival of women with advanced HER2-positive breast cancer. So the next logical step was to transpose this drug to early HER2-positive breast cancer in order to see if it can prevent the development of metastasis, and that's the story I'm going to tell in the next 20 minutes or so. So as you can easily understand, it is absolutely vital today not to miss the diagnosis of this particular breast cancer subtype. And this responsibility is in the hands of our pathologists. They have to evaluate overexpression of the HER2 receptor using immunohistochemistry or amplification of the HER2 gene using fluorescence in situ hybridization. Now, in the last 20 years, 3 strategies have been explored to improve cure rates of early HER2-positive breast cancer. And as we will see, these strategies are based on the development of 4 targeted HER2 drugs that I will briefly describe to you. So there are 2 anti-HER2 monoclonal antibodies, trastuzumab and pertuzumab. One, a small molecule which inhibits the tyrosine kinase of the HER receptors, and the last one is an antibody-drug conjugate. So very briefly, let us explain how these anti-HER2 drugs antagonize cancer cell proliferation. Well, here you can see in pink trastuzumab, the anti-HER2 monoclonal antibody, which, as you can see, binds to the extracellular portion of the HER2 receptor. It's a transmembrane receptor. And trastuzumab binds to the domain which is closest to the membrane. And by doing that, it will disrupt signaling of this potent HER2, HER3 heterodimer and block signal transduction. The second anti-HER2 monoclonal antibody binds to a different epitope in the extracellular portion of the HER2 receptor. It's, in fact, the domain which is responsible for the dimerization of HER2 with other family members, in particular HER3. And that's the mechanism of action of this second anti-HER2 monoclonal antibody. Neratinib is an irreversible tyrosine kinase inhibitor, so it inhibits the tyrosine kinase, which is in the intracellular portion of the receptors. It binds to HER1, HER2, HER4, and it will block signaling through several homodimers or heterodimers. And last but not least, this is a fascinating drug. It's the first antibody-drug conjugate introduced for treatment of women with breast cancer. It's called trastuzumab DM1. And what you can see is that 3 potent cytotoxic molecules that correspond to a drug called maytansine, which is an inhibitor of microtubule assembly, are linked to the antibody trastuzumab through a non-cleavable linker. And this drug behaves like a Troy horse. So trastuzumab will bind to the HER2 overexpressing cancer cells and not, in principle, to the normal cells. And then this complex will be internalized and the cytotoxic drug will be liberated inside the cancer cells. And so this drug has very few side effects. It's associated with an excellent quality of life. Now here are the 3 successive strategies that we have explored in early HER2-positive breast cancer in order to improve the chance of cure. Because here what we want to do is eradicate micrometastasis. We want to cure the patient. The first strategy has been single HER2 blockade based on the parent drug trastuzumab. The second strategy has been to add a second anti-HER2 drug to trastuzumab. And the third strategy has been to use this interesting Troy horse, and we will see how. So, single HER2 blockade with trastuzumab. You know that in breast cancer we prescribe chemotherapy with the goal to eradicate micrometastasis. Well, there have been several randomized trials for these women with HER2-positive early breast cancer that have compared chemotherapy alone or chemotherapy with the addition of trastuzumab given in general for 1 year. And all these trials, with only one exception, have clearly shown a significant reduction in the risk of disease relapse when you add trastuzumab to chemotherapy, and also a significant reduction by something like 33 to 59% in the risk of death from breast cancer. And the blue bar represents the trial that was conducted by the Breast International Group, the HERA trial, which gave an early access to European women to this life-saving drug, trastuzumab. Now, there is a small price to pay for this combination of chemotherapy and trastuzumab, and this is a small risk of cardiac insufficiency ranging from 0.5 to 3%. But the good news is that this trastuzumab-induced cardiomyopathy is far less severe than anthracycline-induced cardiomyopathy and is very often reversible. So the next logical step was, if blocking HER2 with one drug works, probably blocking HER2 with 2 drugs will work even better. And today there are 2 dual HER2 blockade strategies that are approved by the FDA and the EMA. And this is the combination of trastuzumab and pertuzumab, the 2 anti-HER2 monoclonal antibodies, or trastuzumab given for 1 year, followed by neratinib, the small oral molecule also given for 1 year. Now, while we have seen advantages to the use of dual HER2 blockade, we have been a little bit disappointed because the magnitude of the benefit we have seen has been rather modest and in fact confined to women with node-positive disease. So just to show you an example, this is another big trial, Affinity, which compared chemotherapy plus trastuzumab and pertuzumab to chemotherapy plus trastuzumab and placebo. And here you see the 6-year results in terms of disease-free survival. On the left, the node-positive patients. So there you see indeed a 5% reduction in absolute terms in the risk of experiencing a relapse, which is statistically significant and clinically meaningful. But you see for the patients with node-negative disease on the right, no benefit at all. But you can be impressed there by their excellent outcome. So these women with HER2-positive breast cancer, node-negative, have a 95% chance of not experience any relapse in 6 years, the 6 years following surgery. And so it's very difficult to improve upon that. Now, the trials I just discussed with you are adjuvant trials. What this means is that the surgeon resects the tumor in the first place, and then we medical oncologists, we prescribe these expensive and sometimes toxic drugs as blind doctors, because we have no way to evaluate if what we do is helping the patient. And so, starting in 2015, there has been a growing interest in giving these anti-cancer drugs prior to surgery. And this is what we call neoadjuvant medical treatment, which has a big advantage because then you can see if the drugs you are prescribing are shrinking the tumor. And then you can hope that if that's the case, they are probably also efficacious on micrometastasis. So here, we are no longer blind doctors. But there is another interesting feature of this approach, and this is that complete eradication of the tumor at surgery. So no tumor left in the breast and in the nodes. What we call a pathological complete response identifies a group of patients with a very good prognosis, much better than the one of patients with residual disease, which is shown on the right with the curves. And this paradigm shift in the way we treat women with HER2-positive breast cancer has been greatly reinforced with the discovery that there is a drug that can help patients with residual disease. So these patients who have a much worse prognosis, we can do something for them, and this is the introduction of T-DM1, of the Troy horse. And this was elegantly shown in this famous trial, Catherine, where close to 1,500 women with residual disease following neoadjuvant chemotherapy with anti-HER2 drugs were randomized to get either trastuzumab or T-DM1. And T-DM1 was clearly superior with a 50% reduction in the risk of disease relapse, translating into an 11% better outcome at 3 years. So here we are in 2019 with a complex, expensive, one-shoe-fits-all treatment strategy. So for the women we present with tumor greater than 2 centimeters, we give this preoperative chemotherapy, quite aggressive. Then we give 2 anti-HER2 monoclonal antibodies combined with the taxane. At surgery, if there is a pathological complete response, we can continue with the anti-HER2 antibodies alone. And if there is residual disease, the woman will go on and receive 14 cycles of T-DM1. If the tumor also expresses hormone receptors, we will also add endocrine treatment. So this treatment is a treatment that lasts minimum 16 months, maximum 6-7 years. And so we started to think that some women with this disease must be overtreated in this way. And that explains the growing interest in trying to cautiously de-escalate treatment for selected women. So, because the heart can be severely damaged, as I told you, by anthracyclines, this is the first building block that we want to get rid of. And we are close to show that this is possible. Indeed, there has been this elegant Dutch trial that randomized 438 women to receive neoadjuvant chemotherapy regimen without anthracycline or with anthracycline. And they reported identical rates of pathological complete response, quite high, 68%, and identical outcomes at 3 years of follow-up. But look at the confidence interval. It's very broad. It goes from 0.50 to 1.63. So clearly, this is not a trial that gives enough confidence and that can lead to a change in clinical practice. So what we are hoping now is that this much larger trial of the big network will, in a few years from now, lead to a change in clinical practice. So in this trial, you see that we are going to recruit more than 1,000 women with relatively small tumors. We do not want to take women with bulky disease because we don't want to put them at risk. These women will receive neoadjuvant chemotherapy without anthracycline and dual HER2 blockade, the two antibodies. And if at surgery they show this pathological complete response, they will only continue with the anti-HER2 drugs. But for the trial to be successful, these women with a de-escalation of treatment will have to show an excellent outcome. They will have to show relapse-free survival in excess of 94%. Now, what is interesting too here is that the trial is also making a biological hypothesis that takes into account the molecular heterogeneity of HER2-positive breast cancer that we have discovered in the last decade. So, as you can see here, the hypothesis is that the women who will do very well with this less aggressive treatment are women who have a special subtype of HER2-positive breast cancer called HER2-enriched. What does that mean? So here I try to summarize for you what we have learned in terms of heterogeneity of this disease. So first, of course, you need to make sure that the disease is overexpressing HER2. Then you will have already heterogeneity because in 55% of the cases, the hormone receptor will be there, and in 45%, it will not be there. And after that, you can go further in the dissection of the disease. In terms of gene expression, we have seen that there are different subtypes, and the HER2-enriched subtype is the one where the HER2 pathway is, has the highest activity. Then there is also heterogeneity at the level of DNA, and HER2-positive breast cancers can show Pi3k mutations, which is bad because it tells you then that the pathway is permanently activated. And finally, very interestingly, there is also heterogeneity in the microenvironment with a lot of tumor infiltrating lymphocytes in some of these HER2-positive breast cancers and not so much in others. And what we think is that the candidates for chemotherapy-sparing strategies are the women with the HER2-enriched subtype, so this is at the mRNA level, no Pi3k mutations, and a high TIL infiltration. But of course, this is what we need to demonstrate in the decrescendo study. Is it possible that we could get rid completely of chemotherapy? And I personally think the answer is yes. It's going to be for a small group of patients who have HER2-addicted tumors, where we think that the anti-HER2 targeted drugs will be sufficient because they will do a great job. And here comes the power of molecular imaging that we do not exploit enough in oncology. What we have seen is that by using FDG PET, you can make a distinction in these patients with HER2-addicted tumors, where the tumor disappears after 2 weeks of exposure to anti-HER2 monoclonal antibodies. So this is the case of this patient. After 2 weeks, you can no longer see the primary tumor and the nodes. And this is very different for this other patient, in whom, after 2 weeks, you see absolutely no change. And this observation has been exploited by an elegant trial called FERGAIN. In this trial, 356 women with HER2-positive tumors between 1.5 and 5 centimeters underwent a first FDG PET scan. They were then randomized according to a 1-to-4 ratio to receive the standard of care, which is chemotherapy and dual HER2 blockade, or dual HER2 blockade alone, without chemotherapy. And then, after 2 cycles, 6 weeks, the FDG PET scan is repeated. And if there is a good response seen on the FDG PET, the patients continue without chemotherapy until surgery. And the interesting observation is that in these women where no chemotherapy was administered, the rate of pathological complete response was 40%, so a little bit smaller than in the control arm, but very interesting. Now we are waiting for the mature results of this study in terms of what will happen in the following years, in terms of disease-free survival. To finish, very quickly, will we make further progress for residual disease patients? And the answer is likely yes, because we are now seeing the emergence of better antibody-drug conjugates than TDM1, and then also because we are going to explore ways to activate the immune system in this disease, as we have done successfully now in triple-negative breast cancer. So here is an antibody-drug conjugate that already showed superior efficacy to TDM1 in advanced HER2-positive breast cancer. It is on the left there, trastuzumab deruxtecan. So what you can see is that the antibody is the same, it's trastuzumab, but you have 8 molecules of a potent cytotoxic drug that are linked to the antibody. And the cytotoxic drug is a topoisomerase 1 inhibitor and is not, like for TDM1, an anti-microtubule. Another difference is the linker. Here, it's a cleavable linker. And that is a disadvantage in terms of side effect profile, because the drug will have bystander effects, but it could potentially be an advantage in case the tumor is heterogeneous in terms of HER2 expression. So the other possible progress will come from the realization that the mechanism of action of trastuzumab and pertuzumab is not just switching off the HER2 circuit. In fact, what has been discovered by basic scientists is that these antibodies work through innate and adaptive immunity. And this is a very nice experiment that tells the whole story. So these are mice injected with an HER2 overexpressing cell line and treated with the rat homologue of the human anti-HER2 monoclonal antibody. And there are 3 groups of mice. In the wild-type mice, the treatment works beautifully well. Then, in the mice which are knocked out for Fc gamma receptor expression, there are no regressions seen. And then, in mice lacking T and B cells, we see limited tumor regression. And so, the way we think trastuzumab operates is shown here. So, the antibody is in blue, and you see that it is recognizing the HER2 overexpressing cancer cell, which is in orange. But what the antibody will also do, and that was neglected by us for many years, it's that it will recruit Fc receptor gamma expressing cells, like NK cells. So antibody-dependent cellular cytotoxicity will operate and cause cell death with the release of death signals, such as HMGB1, which will then trigger the activation of antigen-presenting cells, so that at the end, CD8-dependent adaptive anti-tumor immunity will be generated. And so today we think that the immune mechanism of action of trastuzumab is more important than the blockade of the signal that I described at the beginning. And so what we will see now with clinical trials that are just starting is that for patients who do not have this pathological complete response and who remain at risk of relapse, maybe trastuzumab deruxtecan will be shown to be superior to TDM1 as a salvage treatment. And there are also clinical trials that are going to look at the addition of an immune checkpoint inhibitor to TDM1 as a way to further improve results. Okay, I think it's time to conclude. I hope I could demonstrate to you that the development of these elegant targeted drugs against the Achilles heel of this disease, which is the HER2 receptor, has translated into significant improvements in outcome for these women, but also that with these smart targeted drugs, there is now a possibility perhaps for some of these women to completely avoid chemotherapy in the future. So I was very lucky to take part in this journey in the last 2 decades, helped by my team that I would like, of course, to thank today. And I also would like to thank the women who participated in all these important clinical trials. Thank you.
Thank you very much for this amazing lecture that really inspired us, both at the basic and translational level. I cannot abstain myself to say that the original discovery of Bob Weinberg was on rats and on rat receptor that was actually mutated in the membrane domain, but in humans, it's the non-mutated gene that is amplified, and that leads to dimerization and activation. So it's amazing that work in rats on mutated receptors. The first antibody was also done against the rat receptor that blocked the new in rats that internalized and destroyed it, and that's what they humanized in Genentech. So that's an example how research in animals can impact really human health. Questions from the audience?
I have a question from Dominique Bron, that you know very well, from Bordeaux. She says, merci Martine pour cet exposé très rassurant. Y a-t-il un âge limite pour cette approche, comorbidité qui augmenterait la toxicité des AC conjugués?
Je ne suis pas sûre que j'ai compris tout à fait, j'ai parlé un peu vite. Donc,
oui.
est-ce que...
Donc, y a-t-il un âge limite pour cette approche et des comorbidités qui augmenteraient la toxicité des AC conjugués?
Bon, je crois que l'âge, certainement, est un facteur de risque pour les effets cardiotoxiques de ces thérapies anti-HR2. Ça a été montré. Un des facteurs de risque dont on tient compte, et donc on va rarement utiliser effectivement les anthracyclines chez des patients de plus de 65 ans. Maintenant, jusqu'à présent, pour les données qu'on a accumulées avec les antibody drug conjugates, on n'a pas mis en évidence de toxicité plus importante chez les patientes âgées. Voilà, mais c'est certainement quelque chose qu'il va falloir surveiller de près, surtout que le cancer du sein est une maladie fréquente et bien sûr fréquente aussi chez les femmes de plus de 65 ans.
Je vais laisser la professeure Bron vous répondre puisqu'elle est avec nous en direct et vous dire si elle a d'autres questions pour vous. Dominique Bron.
Ben merci Martine, c'est super exposé. C'est vrai que c'est très rassurant de voir l'évolution pour un mauvais cancer du sein. Mais je crois que tu as répondu à ma question puisqu'on essaye d'aller vers des traitements sans chimiothérapie parce que le cancer du sein touche quand même des gens de plus en plus âgés aussi. Et je ne sais pas si en dehors de la chimiothérapie et de l'anti-HR2, est-ce que le fait qu'il soit conjugué à un dérivé neurotoxique, ça vous pose des problèmes?
Mais je crois que ça, c'est toute la beauté de la chimie qui est derrière ces antibody drug conjugates, qui ne seront pas tous égaux. Je pense que certaines firmes vont développer des molécules plus performantes que d'autres en s'attachant à toutes sortes de petits détails qui sont très très importants, comme par exemple la qualité de la liaison entre l'anticorps et la molécule cytotoxique. Et puis la molécule cytotoxique en elle-même va évidemment être très importante. Donc voilà, donc je pense simplement qu'il y a dans 10-15 ans, on ne va plus prescrire de chimiothérapie. C'est mon rêve. Je pense qu'on aura plein d'antibody drug conjugates. Je ne dis pas que ces molécules sont parfaites, parce que vous avez vu que si le lien est clivable, malgré tout, il y a une toxicité qui peut se manifester, mais ce sera quand même une manière incroyablement plus élégante d'essayer de traiter les cancers que par la chimiothérapie libre telle qu'elle est utilisée aujourd'hui.
Merci à toutes les deux. D'autres questions dans la salle?
I will make a comment. interestingly enough, this antibody, when it enters the cell, it will go to endosomes and then lysosomes. Now, as a function of the pH and the quality of the linker, some of the payloads would be released and some will not. Some, therefore, would recycle back, or some would get into the cytoplasm and then to the nucleus. So I think there's a lot of potential in actually varying the linker and the payload. So we're going to see that also for other antibodies, I think.
Yeah, I think I read that there are more than 100 antibody-drug conjugates now in trials in different diseases, not only breast cancer, of course. Yeah.
So one question I had was, there was some cardiotoxicity, as you know very well, for anti-HER2. Do you know if when you couple it with different things and different antibodies have different levels of cardiotoxicity, is just the trastuzumab that has it, or also all of them?
Well, for example, pertuzumab also has some cardiotoxicity, but what was very reassuring was that when we used the two drugs together, we were nervous. We thought perhaps the cardiotoxicity will increase, and it's minimally increased to a non-significant degree, which was very reassuring.
That's very nice. It's wonderful.
Merci, professeur Piccart. Associer l'hormonothérapie aux nouvelles thérapies. Ah oui, le livre, pardon, professeur, j'allais vous faire repartir sans le livre de l'Académie, qui est quand même précieux. Associer l'hormonothérapie aux nouvelles thérapies ciblées, c'est l'évolution sur laquelle nous allons à présent nous arrêter, avec une incursion sur la piste des conjugués anticorps-médicaments qui pourrait constituer la dernière révolution en matière de thérapie combinée. Monsieur le Président.
It's a really great pleasure for me to introduce François P, who is a professor of medicine at Université Catholique de Louvain, where he teaches medical management of breast cancer and hereditary cancer predisposition syndromes. He is both a medical oncologist but also a clinical geneticist. He has actually done his PhD in genetics linked also to hematological diseases. And now he specializes in the care of patients with breast cancer and management of hereditary breast and ovarian cancer. He's very active in research on next-generation sequencing and stratification of the breast and ovarian cancer. He is head of the research section within the breast cancer clinic. He obtained his medical education from our university in 2004. He underwent a number of training positions in internal medicine and medical oncology, both in Belgium and in France, most notably Institut Curie in Paris. He also has an oncogenetics degree from Université Paris 7. And he is also active in the field of drug development, and he is currently the president of the Belgian Society of Senology and a member of ASCO, ESMO, BSMO, and the American Association for Cancer Research. Thank you very much. Looking forward to your presentation.
Monsieur le Président, Monsieur le Secrétaire perpétuel, Mesdames et Messieurs, it's a great honor for me to be standing here in front of you, and I'm really very glad to follow in footsteps of giants of oncology that you had the privilege to hear this morning. As an introduction, I have conflicts of interest with all pharmaceutical companies whose drugs I will present today, and I will today discuss mainly luminal breast cancer. So Professor Piccart already introduced the different subtypes of breast cancer, so we will focus on subtypes of breast cancer that express estrogen receptors. These subtypes of breast cancer are the most frequent ones, so almost 3/4 of all breast cancer cases have this expression of estrogen receptor. And why would we like to improve our treatments and not use classical endocrine therapy for these patients? Well, mainly because these estrogen receptor positive breast cancers have a tendency to relapse a lot late in the course of the follow-up. You see here patients with more than 4 positive lymph nodes, estrogen receptor positive breast cancers. Half of them will relapse after 20 years, and these relapses are, in most cases, unfortunately, still deadly today. So it's very important to improve endocrine therapy for patients with early disease. But it's also important to improve treatments of patients with metastatic breast cancer. This is a study that was published 4 years ago now concerning the outcomes of patients with metastatic breast cancer treated at French Centre de lutte contre le cancer. So you saw presentations of 2 distinguished members of these centers. These centers treat their patients extremely well, but nonetheless, unfortunately, median overall survival of metastatic breast cancer remains poor. It's approximately 3 years median overall survival at the moment, and the only subtype of metastatic breast cancer that has shown an improvement in survival over time is HER2-positive disease. You can see that patients who were diagnosed before 2008 here on the lower curve have a poorer prognosis than patients who were diagnosed after 2013, and this of course is due to the advancement of these new therapies that Professor Piccart so elegantly described. Unfortunately, in estrogen receptor positive disease, HER2 negative subtype, there was no improvement in median overall survival, at least on the curves that were generated for patients who were treated after 2013. But we hope, of course, with the advancements that I will show you now, that this curve here will also start to improve. And just a quick note on the worst subtype of breast cancer that we will not discuss today, triple-negative breast cancer, median overall survival from diagnosis is just a little bit over 1 year. So that's really a very, very bad prognosis. So why, in summary, do we need better therapies for these estrogen receptor positive, HER2 negative breast cancers? It's because it's the most frequent subtype. It's the subtype with the highest rate of late relapse, and there was very little improvement for these patients who were classically treated with endocrine therapy and chemotherapy. Endocrine therapy, as you know, was developed well before my time. It was developed in the 19th century when surgeons discovered that by removing the ovaries, they could make most breast cancer tumors shrink. We now have more elegant ways of dealing with endocrine receptors than just removing the ovaries. And you know that we can use LHRH agonists to suppress the ovaries without removing them. We can use aromatase inhibitors, and we can use anti-estrogens. So these are the tools that we had in our toolbox. How could we improve the efficacy of our treatments by using these tools? Well, one of the first ways to do this was to increase the duration of the treatment. Classically, in the adjuvant setting, endocrine therapy would be given for 5 years. We now have several trials, I will not go through all of them, showing that when you increase the duration of endocrine therapy, you can increase the likelihood of patients remaining disease-free and also of patients surviving. So this was done with tamoxifen in the ATLAS study, and the ATOM study also showed that consistently when you increase the duration of endocrine therapy, you can increase the outcomes of patients. For tamoxifen, we are now at 10 years for most patients. For aromatase inhibitors, the 7-year mark seems to be the limit, at least for most patients, and we now have tools that we can use to identify patients who are at higher risk of late relapse and who may benefit from these approaches. But that's not the topic of the talk today. Another way of improving outcomes is to use better drugs, and that's why we now use aromatase inhibitors instead of tamoxifen for most, if not all, postmenopausal patients. You can see here that by using an aromatase inhibitor for 5 years instead of tamoxifen, you can reduce the likelihood of the patient recurring from her breast cancer, and you can also decrease her risk of dying. In premenopausal patients, in order to use aromatase inhibitors, you have to also use ovarian function suppression, and there were several trials looking at the difference between patients treated with tamoxifen, tamoxifen plus ovarian function suppression, or an aromatase inhibitor plus ovarian function suppression. And these trials were analyzed jointly. It's the soft and the text trials. And for premenopausal patients with a high risk of recurrence, the current approach is to use an aromatase inhibitor plus ovarian function suppression, although when you look at overall survival, the differences are very small, and this approach probably benefits the very young, so patients below the age of 35. Using these new, not so new drugs now, increases toxicity. And this is really something that is very worrisome for a medical oncologist who sees patients in follow-up for 5 to 10 years, some even longer than that. You see here very interesting results on quality of life that were generated within the French Canto cohort study. And you can see the evolution of patients' quality of life from the start of their treatment if they are treated with various treatment modalities. So patients who do not receive any endocrine therapy or chemotherapy don't have any significant reduction in quality of life over time. Patients who are only treated with chemotherapy, here in green, see their quality of life decrease, but it goes back up again after the end of their chemotherapy. On the other hand, patients who are treated either with endocrine therapy alone or endocrine therapy with chemotherapy have consistently lower quality of life over time. So what's important for quality of life is endocrine therapy and not so much chemotherapy, at least in the long run. And that's very surprising to a medical oncologist. Here are the guidelines that we currently use in Belgium to treat our patients. So you see that patients with low-risk disease are treated with tamoxifen if they are premenopausal and are treated with an aromatase inhibitor and ovarian function suppression if they are at high risk of relapse. And in the middle, we discuss. Now there are, of course, and that's the topic of my talk, ways to improve the efficacy of endocrine therapy beyond just using another drug. And these are all the different targets that we could use to increase the efficacy of endocrine therapy alone. We could use treatments targeting Pi3k, mTOR, Cdk46, and these will be the different parts of my, the next part of my presentation. We will also briefly discuss PARP inhibitors because I think they are very important in luminal disease as well. And then a few words on antibody-drug conjugates beyond what Professor Piccart already told you in HER2-positive disease. So let's start with the Cdk46 inhibitors, which in my opinion are the biggest revolution in the treatment of ER-positive, HER2-negative disease. So CDK4 and 6 interact with cyclin D, and they are important in the cell cycle regulation. So if you block CDK4 and 6, you will block the cell in a state between the G1 and the S phase. The cell will not be able to progress into mitosis. The first trial to show an improvement in overall survival using this approach, so a combination of a CDK46 inhibitor and endocrine therapy, was the Monalisa Ii study, whose results were presented recently at a major congress. And in this trial, patients with metastatic breast cancer, ER-positive, HER2-negative, no prior treatment, were randomized between endocrine therapy alone with a placebo or endocrine therapy with ribociclib, which is one of the 3 CDK46 inhibitors. And what we were shown very recently is that using this approach, you can actually increase median overall survival by 1 year. So hitting the 5-year mark, which is very, very important in this disease. All 3 drugs, palbociclib, ribociclib and abemaciclib have shown consistent benefit in progression-free survival, and the hazard ratios are the same for all these drugs in terms of PFS. Concerning OS, we only have one study that read out, so we don't know yet what the outcomes will be, but in later lines, there we see consistent benefit of all three Cdk46 inhibitors. So I wouldn't want to promote one over the other. So these three Cdk46 inhibitors, when added to endocrine therapy, will increase progression-free survival, and we now have data on OS for one of these. The side effects are not negligible because patients will take these drugs for up to 3.5 years in the metastatic setting, and they will probably experience side effects like neutropenia, which is usually non-febrile, so not so worrisome. There may be some drug interactions and also some diarrhea, especially for abemaciclib. Of course, when we've shown that a drug is effective in the metastatic setting, we always want to use this new tool in the early setting, and that's why several trials were conducted using these three drugs. The trial that showed the most beneficial effect was Monalisa Ii. In this trial, patients with a very high risk of relapse, so again, ER positive, HER2 negative, very high risk of relapse. So for instance, more than 4 lymph nodes involved were randomized to either receiving endocrine therapy alone or endocrine therapy plus abemaciclib for 2 years. We don't have any data on overall survival yet for these trials, but for the abema trial, we now know that it increases the likelihood of being disease-free after 3 years. You see here that it increases numerically the likelihood by more than 5%. So this drug has now been approved by EMA and by the FDA. There are other drugs that can be administered in combination with endocrine therapy. Let's briefly discuss Pi3k inhibitors. So Pi3k is part of this Pi3k-AKT-mTOR pathway that plays a role in malignant transformation, but also cancer progression and resistance to endocrine therapy. We know that 40% of patients with ER-positive, HER2-negative disease will have mutations in PIK3CA, and we can, of course, find this using next-generation sequencing, which is the usual approach, at least in this country. And we now have drugs that can target the PI3K alpha isoform of the protein. So PIK3CA is the gene and PI3K is the protein. Alpelisib is the most promising drugs. We now have results of a phase 3 trial that was presented by Fabrice André. And in this trial, patients who had progressed on prior endocrine therapy were randomized between either fulvestrant alone or fulvestrant plus alpelisib. And let's focus on the cohort of patients who had PIK3CA mutations. So these represent 40% of these patients. For these patients, Fabrice showed in his trial that using a Pi3k inhibitor in combination with endocrine therapy increases progression-free survival with a hazard ratio of 0.65. Unfortunately, there was no statistically significant improvement in overall survival, and there are some toxic side effects of this drug, mainly hyperglycemia, diarrhea, rash, and stomatitis. Currently, we are not, although the drug has been approved by EMA, we are not allowed to use it in Belgium within the reimbursement system because of the lack of overall survival data and the side effect profile. The drug was not reimbursed by inavolisib. Now, let's move to an older drug, which also has a role in the Pi3k-AKT-mTOR pathway, mainly on mTOR itself, it's everolimus. It's, of course, always a little bit difficult to present trial data in front of the person who was one of the chairs of the trial. The Bolero 2 trial was conducted in quite similar patients to the SOLAR-1 population, so patients who had progressed on prior endocrine therapy, and these patients were randomized between receiving either exemestane, so endocrine therapy alone, or exemestane plus everolimus. And this trial also showed an improvement in progression-free survival, but no statistically significant improvement in overall survival, although there was a numeric advantage for using everolimus, and this drug is approved in Belgium, so we can still use it, and we can use it independently of the PIK3CA mutation status. Side effect profile quite similar to alpelisib. Classically, historically, when patients were treated with endocrine therapy in first lines and progressed, we had to resort to chemotherapy. But we now have other ways of treating these patients. I will discuss PARP inhibitors and maybe the future antibody-drug conjugates, at least for part of these patients. PARP, as you well know, is an enzyme that is involved in DNA repair and more precisely in base excision repair. Using PARP inhibitors is based on a theory of synthetic lethality. So when a tumor cell sees their DNA being damaged, the normal tumor cell, so a tumor cell that is efficiently repairing their DNA, can repair it using base excision repair, which depends on PARP, or homologous recombination, which depends on the BRCA status, so BRCA1 or BRCA2. And these cells then remain viable. In a patient with BRCA deficient cancer, so a patient who has a constitutional alteration on BRCA1 or BRCA2, homologous recombination no longer works properly in tumor cells. And so these tumors are completely dependent on base excision repair to remain viable. By blocking base excision repair in these patients who have these specific tumor alterations, the cells no longer are able to repair their DNA and die. At least that's the theory, but it indeed works in patients. Usually BRCA1 or BRCA2 mutations are investigated in families with a large number of breast cancer patients, ovarian cancer patients, or in triple-negative disease. But the Olympiad study also included patients with estrogen receptor positive disease. All were HER2 negative. In this trial, patients were treated with a PARP inhibitor or, and this was randomized, or chemotherapy of physician's choice within a certain subset of chemotherapies that were allowed. And you can see that patients who were treated with the PARP inhibitor had better progression-free survival than the patients who were treated with chemotherapy. Unfortunately, the PFS of 7 months was quite disappointing to me, to be honest, but we now know that these tumor cells regain BRCA functionality over time when exposed to PARP inhibitors. This study was not a standalone study because there is another study called EMBRACA that used another PARP inhibitor, talazoparib, and it was actually designed exactly in the same way. You can make a copy-paste between Olympiad and EMBRACA, and the results are also quite similar because you also see an improvement, a modest, in my opinion, improvement in progression-free survival between patients who were treated with talazoparib and patients who were treated with chemotherapy. Final overall survival analysis did not show any significant benefit. And again, now that we have a drug that seems to be interesting in late-stage disease, we now also use it in early disease, here in combination with endocrine therapy in patients who are ER positive or in monotherapy in patients who are triple negative. So these are patients who were treated either with neoadjuvant chemotherapy and did not respond well to their chemotherapy, or who had, again, very bulky disease, patients with more than 4 lymph nodes involved. If they had ER-positive, HER2-negative disease, they were treated with adjuvant endocrine therapy, and they were randomized between receiving 1 year of olaparib, the PARP inhibitor, or a placebo. And you can see here, these are patients both triple negative and ER-positive, HER2-negative. You can see here that invasive disease-free survival at 3 years is improved in patients who took 1 year of olaparib. It's the same for distant disease-free survival, so a surrogate, I think, in my opinion at least, of overall survival, because, as you know, most patients who develop distant disease, so metastasis, will eventually pass away because of their disease. So a new approach using PARP inhibitors. And then maybe the future, antibody-drug conjugates. Professor Piccart already introduced trastuzumab deruxtecan. So very briefly, it's an antibody-drug conjugate that targets HER2 and that is linked to a very potent drug. The DAISY study was presented at San Antonio and was updated at ESMO Breast this week. Actually, these are the slides from San Antonio. In this trial, patients were treated with trastuzumab deruxtecan, whatever their HER2 status. But there were 3 cohorts. So there was cohort 1 with the true HER2-positive breast cancers, cohort 3 with the true HER2-negative, so 0 expression of HER2, and then cohort 2, in which patients had an expression of HER2 by immunohistochemistry, but no HER2 amplification. And if we just focus here on cohort 2 and the hormone receptor positive cancers, we can see that there were responses. You can see here on the waterfall plot, and in my opinion, interesting responses. And you can even see responses in patients who did not have any expression of HER2, at least measurable by immunohistochemistry. And this also translates into progression-free survival that is, of course, improved more dramatically in patients with HER2-positive disease, but in the hormone receptor-positive subset of patients with low or no expression of HER2, you see interesting PFS results of 6.9 or 4.5 months. So these are also there is also a new approach that could be used in our patients. So for HER2-negative, estrogen receptor-positive disease, we now always go for endocrine therapy in combination with all these new drugs, then chemotherapy, the only exception being visceral crisis, so really very bulky metastatic disease that impairs the patient's prognosis within the next few weeks. That would be my definition. We rarely see these patients nowadays, but when there's no visceral crisis, then we go for endocrine therapy in combination with Cdk46 inhibitors, followed by endocrine therapy with Pi3k inhibitors if there is a PIK3CA mutation and you have access to the drug. Otherwise, you can always use everolimus, so the mTOR inhibitor. And then, of course, we have olaparib or talazoparib if there is a mutation on BRCA. Maybe somewhere here the antibody-drug conjugates. And then finally, what we all want to avoid as medical oncologists, chemotherapy. And I share your hope, and I hope it's not just hope, but also a vision that we will get rid of chemotherapy within our lifetime. So to conclude, Mr. President, we now use endocrine therapy for longer duration in the adjuvant setting. We use AIs in combination with OFS if premenopausal instead of tamoxifen. We add new drugs to the mix, and we have hope to get rid of chemotherapy for patients who progress afterwards. And on this note, I give the floor back to you.
Thank you very much. Extremely interesting. Looking forward for questions. From the audience, any question? Yes.
Thank you for your lecture. I have a question about breast cancer in men. Is it important difference in the treatment and in the characteristic of the tumors?
That's a very interesting topic you're bringing forward. Breast cancer is diagnosed in 1 out of 800 men approximately, so it's 1% of all breast cancer cases. There are around 120 each year in this country. So, and it's often neglected. So very often they will be diagnosed with later stage disease than women. Of course, we don't have randomized trials with all these new drugs that only focused on men, but thankfully many of these trials now also include men in their inclusion criteria. And so the approach would be indeed to use the same drugs than in women, with the caveat that ovarian function suppression has to be, well, OFS, it's not really ovarian function suppression, but LHRH agonists, let's put it this way, have to be used in these patients when we use endocrine therapy.
On a une question de YouTube du professeur, enfin du docteur, j'imagine, Jean-Paul Salmon, pardon, qui nous demande sur quel rationnel limiter l'accès des anti-PARP aux mutations BRCA germinales et ne pas l'étendre aux mutations BRCA somatiques.
So the question of my good colleague Dr. Salmon is whether we should extend the use of PARP inhibitors to patients with somatic BRCA mutations, and so go beyond the germinal mutations. Contrary to ovarian cancer, in breast cancer, somatic BRCA mutations in the absence of constitutional mutations are quite rare, but they exist. We don't have data, unfortunately, for these patients concerning the use of PARP inhibitors because of the inclusion criteria of the studies, but I completely share your enthusiasm on also using these drugs in this very rare subpopulation, indeed.
Merci, professeur. D'autres questions? Professeur Casimir, monsieur le secrétaire perpétuel. Merci. C'est maintenant du concept de maladie oligométastatique que nous allons parler. Le choix de l'imagerie est capital. C'est ce que va nous expliquer en détail l'un des membres de l'ARMB. Monsieur le Président, à vous l'honneur de l'introduire.
Thank you very much. So we continue the second part of this workshop. I should have said last time that now we are in the second part because we had a different schedule of breaks, which is progress in the management of metastatic disease. So after learning about combined therapies from François P, we go into oligometastatic disease, reasoned approach using modern imaging by Frédéric E. Frédéric E is a full professor ordinaire of radiology at the Clinique Universitaire Saint-Luc at our university. He is associate chair of the Department of Medical Imaging and chair of the Medical Imaging Research Pole of the Institut de Recherche Expérimentale at our university. His activities combine clinical work, teaching, and research. His area of expertise is really around the use of MRI in tumoral and inflammatory musculoskeletal disorders and the development of modern imaging to improve detection and treatment of metastases of solid cancer and multiple myeloma. He is vice chairing the imaging group of the ERTC, where he also leads the bone metastasis and oligometastatic cancer research subcommittee. He annually gives lectures at the European Congress of Radiology, International Skeletal Society, and others. He is author of more than 250 peer-reviewed papers, and of course he is an elected member of our academy. Dr. Le Couvet, thank you very much for your lecture.
Merci, Monsieur le Président, pour cette gentille introduction. Merci, Monsieur le Secrétaire perpétuel, pour votre accueil. I will switch to English, and before moving on to my talk, I would like to thank again both the Academy for making this symposium possible, and most importantly, our guest lecturer who made who came sometimes from very far and really contributed to the success of this morning. We really appreciate and measure the privilege we have to have them amongst us. So let's move on to this particular stage of cancer, which is called oligometastatic disease, which is generating a growing interest in the community, also in breast cancer. I will try to illustrate how the use of modern imaging can help in a reasoned approach of this new concept. So I have no conflict of interest. This is the map of my talk. I will begin with some definitions. What is oligometastatic disease? What are the therapeutic possibilities, and especially the so-called metastatic directed treatments that could be, that can be proposed for this particular disease? I will, as I mentioned, illustrate the important role of the imaging generation before focusing or proposing trials that should be performed for a reasoned approach of this condition. To make it simple, oligometastatic disease is a concept that postulates that between the stage of localized cancer and polymetastatic disease, there is an intermediate step characterized by a limited number of metastases. And the idea or the hope behind this concept is that specific metastatic directed treatments can help improving the outcome of those patients, improving overall survival, delaying the need for systemic therapy, and why not curing the disease. But we must be aware that this is mainly and largely unverified, and that the use, for example, of metastatic directed treatments is often empirical. So the definition, I took this one from Astro, which is I think a good definition. It is defined, oligometastatic disease, as a state in which all tumoral location can be treated with a curative intent, as I mentioned before. Regarding the threshold, the maximal threshold in terms of number of lesions and number of involved organs, the definitions is quite variable. If we look sometimes at different definitions from different societies regarding the same cancer, we observe, for example, that the maximum number of lesions to be considered as oligometastatic disease can differ from one to the other society. Oligometastatic disease can also be observed at different stages of the disease. It can be observed in newly diagnosed cancer, either exactly at the same time of the disease being then synchronous. It can occur a little bit later than being called metachronous. It can also be observed quite later in the disease course after first-line treatment. It's called oligorecurrent disease, and it can even be observed, for example, in patients with polymetastatic disease who shall respond to a first line of treatment and only remain with several metastases, which are then called induced oligometastatic disease. If you want to read more about these definitions and the different stages during the disease course, you can have a look at this paper, which is the result of a collaboration between Astro and EORTC, and definitely shows where oligometastasis can be observed in cancer. With regard to the treatments, you see that the idea of metastatic directed therapies is not new. Early on in 1939, for example, surgical resection of a single lung metastasis from a renal cancer was proposed. The same surgical solution has been proposed in breast cancer. You see in this paper that patient with several very limited number of liver metastases could be treated with surgical wedge resection within the liver, and beside surgery, interventional radiology may also play a role in this indication with local invasive methods like thermo or cryoablation. That can be proposed, but the most important role, we already heard about radiation therapy today, will be held by radiation therapy using the so-called stereotactic body irradiation, which means delivery of high dose with high geographic, I will say, precision with high dose per fraction and a limited number of fraction with proven low rate of complication and high rate of local control. Bone, like spinal, for example, liver and lung metastasis can be addressed, and you see that modern imaging already plays a role for the careful definition of the target of the treatment. Let's move on to imaging, and I told you that imaging generation does matter. I can illustrate that by comparing these graphs, for example, if we use standard imaging modalities, and this is covering bone scintigraphy, for example, or CT, it is proven that we will have a much later delayed diagnosis of the metastatic disease compared to more recent modern imaging modalities. I can illustrate that with the example of this patient who presents one single right iliac metastasis on the bone scan. If we look at more modern recent imaging, it could be PET, in this case it's all body MR, you see that we are able to detect the same right iliac lesion, but you see that the technique also demonstrates 5, 6 or 7 additional lesions, so the disease is not oligometastatic anymore. Most interestingly, in this other patient, you see that despite high risk of cancer, the bone scan is negative, but if we look at the same modern imaging, you see that it demonstrates 2 foci that could be a target for directed treatment, so this represents oligometastatic disease. Within the EORTC imaging group, we focused on these specific questions, and we focused on the big providers of metastasis and oligometastatic disease, which is colon, lung, prostate, and for sure breast cancer. We came to the conclusion that standard imaging modalities, which is still often standard of care, may be insufficient, and that modern imaging should be used for a confident and early diagnosis of oligometastatic disease. So in all these cancers, we reviewed the stages of the disease where metastatic screening is necessary, what is defined as high risk of metastatic disease and indication of imaging. And again, we had a look at the guidelines. You see that chest, abdominal, CT, bone scintigraphy is still recommended. We think that for a confident diagnosis of oligometastatic disease, we should move to more recent modalities, which covers FDG, PET, MRI, especially for the liver, or all-body MRI. Our imaging modalities should not only be able of a confident and early diagnosis of the disease, as I mentioned, but also, as I illustrated, they should be able to guide the treatment to precisely delineate the target, but they should also be able to assess the response, and why not provide endpoints for clinical trials by demonstrating, for example, the presence or absence of local control, the presence or absence of complications, define the progression-free or metastatic-free survival. So we think definitely that modern imaging is needed. This modern imaging, if possible, should do a one-step staging of metastatic disease, which in the case of breast cancer means covering lymph nodes, bone, lung, liver, and brain. Again, this will be feasible using FDG, PET, or MRI. The main questions before addressing or using our metastatic directed treatment is the patient truly oligometastatic disease, oligometastatic, sorry. And I illustrate that with several examples. This is a patient with newly diagnosed breast cancer, very high risk of metastasis, reason why metastatic screening is requested. In first line, bone scintigraphy and CT, so the standard imaging modalities were requested, showing no lesion. At the same moment, I show you the corresponding FDG PET and all-body MR, which both detect one single vertebral lesion within the T2 vertebra. But if we look closer on the all-body MR, for example, we suspect several hepatic lesions, which were confirmed by the diffusion-weighted MRI of the liver, which is the standard for the diagnosis of hepatic metastasis. In this case, the patient had probably 8 liver metastases, so the disease was not oligometastatic anymore, and systemic treatment was more indicated. Another example of a patient later on during the disease, she was treated 3 years ago and comes back because of symptoms. She has thoracolumbar pain. Again, standard imaging modalities requested in first line does not show abnormalities. I show you again the same correspondence between PET-CT and all-body MR, both demonstrating the presence of one single vertebral lesion, in this case within T9, because the patient had no other lung or liver metastasis, for example, but also because of the mass effect on the spinal canal associated with that lesion. Stereotactic radiation therapy was not chosen, but this patient was treated with surgery. You see that she had a vertebrectomy and spinal stabilization with additional systemic treatment guided by the molecular profile of the resected metastasis. 4 years later, this patient was still free of metastasis. So in advanced stage disease, the detection of the oligo recurrence may be very difficult, like in this patient, for example. After several episodes of metastatic disease and after several lines of systemic treatment, the bones quite frequently presents this diffuse alteration showing sclerosis, heterogeneities, and it's difficult to say where the active disease is located. And in this patient, after a new recurrence of the marker, the clinician wanted to know where the or at least the recurrence was located. He was convinced on this CT that this lytic area within the right iliac crest was the site, because of its difference from the rest, was the site of the recurrence. But again, looking at modern imaging, again, MRI and PET-CT showing the same results, you see that the active disease was confined to the left iliac crest and left sacrum. So this patient, and because the clinician also wanted to know about the molecular profile of the recurrence, the clinician asked a double biopsy, in this case of the lytic lesion and the active left portion of the pelvis. You see that within the lytic lesion that was inactive on modern imaging, there was only scar tissue, whereas on the other side, there was active tumor. So the patient was treated, of course, with systemic treatment, but also with metastatic directed therapy to the left portion of the pelvis. As I mentioned, we should also address the question, is the patient responding? We've seen with Dr. Piccart similar images to this one. This is again PET-CT and MRI. You see that the techniques are able to detect not only active lymph nodes, but these two bone metastasis, and both techniques do agree. I take one of them after several cycles of treatment. You see how they are able to demonstrate the response. So we have the concept, oligometastatic disease. We have the therapeutic tools, metastatic directed treatments. We have modern imaging modalities for an early diagnosis of the disease, but are we useful by doing that for the patient? Do we improve survival? Do we improve quality of life? So there is a need for clinical trials, and this is nicely suggested in the title of this paper dedicated to oligometastatic disease in prostate cancer. We should not put the cart before the horse, and that means that we need clinical trials. We need trials, and there are mainly two types of trials. Some of them are called observational trials or registries, which means looking at what is done with its differences and how it influences patient survival. In the setting of oligometastatic disease, there is a huge project, which is a collaboration between EORTC and ESTRO, which consists at observing what is done in the biggest providers of oligometastasis in their different affiliated centers in terms of indications, in terms of radiation therapy techniques, dose, fraction, and so on, and how it influences patient survival to see if something has to be privileged, for example. Some of these observational studies have been focusing on breast cancer and have been published. So these are two studies in metastatic breast cancer. You see that the difference is the locations of the metastasis. In the first one, it's more lung and liver, whereas bone and nodes locations are predominant in the second paper. It is interesting to note that the rate of local control and progression-free survival are better in this patient with bone and nodes lesions, suggesting that these anatomic locations might be better indications for a specific metastatic directed approach. After observational trials, then there is a need for prospective randomized trials, which means comparing populations with treatments taking into account or not the presence of oligometastatic disease. This is a patient with a trial in patient with several different primary cancers, a limited number of breast cancer, but you see interestingly that the patient treated with standard of care systemic treatment plus stereotactic, so metastatic directed treatment, the blue survivor curves have better overall survival and progression-free survival than patients treated with standard of care alone. So this was a phase 2 study. There is, as far as I know, no published phase 3 trials. There are enrolling ongoing trials dedicated to breast cancer, which is very interesting. We regret that in several of them, older imaging modalities are still allowed for enrollment and diagnosis of oligometastatic disease. From our side, within the EORTC imaging group, we set up a task force to address this question, reviewing what is done, what is needed, and trying to elaborate recommendations. We put together clinicians, radiation therapy specialists, nuclear medicine physicians, and radiologists, and together, after careful review, redacted a questionnaire made of, you see, more than 100 questions addressing the definition that should be kept for oligometastatic disease, the indications, should we screen all patients, should we have the same indications as for usual metastatic screening in breast cancer, what is the optimal imaging modality, which may vary according to the primary, according to the histologic and molecular subtype of breast cancer, what treatments are available and which one should we privilege, and which are the trials to design. So we sent this questionnaire to specialists, like it is traditionally done in Delphi processes. You see that you probably know several of them. This is again a group of experts in surgery, clinical oncology, gynecology, radiation therapy, nuclear medicine, physicians and radiologists. And the results of this questionnaire and this Delphi process will be published very soon. In this paper, we will also propose some trials that should be interesting, at least some trial designs. For example, randomizing patients with high risk of metastasis using either standard imaging and modern imaging to see if the early diagnosis really changes something for the patient. We can also, for example, use standard imaging and modern imaging one after the other to make sure that the oligometastatic patient we diagnosed are really oligometastatic, and in these patients compare again standard of care versus standard of care plus metastatic directed treatments. So this brings us to my conclusions. I think that oligometastatic disease really raises and deserves specific approaches. Metastatic directed treatments are available. I'm sure that the imaging generation does matter, and trials are really necessary because we are facing a difficult situation. I would say an equation with several unknown factors. I thank you for your attention.
Thank you very much. Questions in the audience? I suspect that our digital world is reflecting on it. But it might be then a good idea to, do we have the accreditation for this session? Good, good. So,
of course, we have the accreditation, and you can send your email as of now to the address that you know by heart, which is contact@armb.be, donc contact@armb.be. And of course, do not forget to mention your first name, and number of INAMI number. If you watch us on YouTube, and even if you are not member of the Academy, of course you can send us an email. So contact@armb.be.
yes, yes.
Professor Piccart.
I think it's very interesting, but is it reimbursed? I was told that it takes 45 minutes of a radiologist. It's not reimbursed, right?
Yes, whole-body MR is very promising as a technique for detecting metastasis or other tumoral lesions within the body. As you mentioned, it is not reimbursed in Belgium. It takes at least 30 minutes. It should be reimbursed, but it is under discussion, indeed. We do it mainly in a research perspective, comparing it with other techniques, as I illustrated with PET.
François?
Another question?
Very interesting talk, Frédéric. Thank you. I also have a question on this whole body MRI imaging. Are there any artificial intelligence tools that could be used to direct the radiologist to the lesions that may be suspect? Because I guess it takes a lot of time to read, not just to have the scan done, but also to read.
It's an interesting question. Indeed, artificial intelligence is expected to help radiologists, not only in whole body. For example, for chest lesion detection, it is almost available. And we are working also on it on whole body imaging techniques, but it is also valuable for PET. So it's called CAD, computer-aided decision, is definitely on its way, I would say.
So we have now the special moment of the reward.
Merci, professeur. Et pour refermer ce symposium, un focus maintenant sur le programme académique Aurora, mené dans 11 pays européens. Un programme centré sur l'approche moléculaire de la maladie métastatique. Monsieur le Président, à vous d'introduire le dernier orateur.
Thank you very much. So it's my great pleasure to introduce Dr. Philippe Aftimos. He is a medical oncologist and clinical trial development leader at the Clinical Trial Conduct Unit of Institut Jules Bordet, which is, as you know, a comprehensive cancer center in Brussels. He works in the fields of cancer, of breast cancer, new drug development, and precision medicine. He heads a new program called the New Drug Development Program at Institut Jules Bordet. He has contributed to the development of novel monoclonal antibodies and antibody-drug conjugates for the treatment of breast cancer and also novel endocrine therapies. He leads multiple projects that are now involving epigenetics modifier in cancer treatment. He is a physician scientist and is member of the OncoDistinct Network think tank and vice chairs the Scientific Executive Committee of the International Breast Cancer Study Group. He has participated in the field of precision medicine in drafting the national Belgian NGS guidelines. And obviously, he is co-PI of the Aurora program, a large European molecular screening program launched by the Breast International Group. He is also co-PI of the Belgian Society of Medical Oncology Precision Medicine program and co-created and leads the Belgian National Molecular Tumor Board. Dr. Aftimos, welcome to the Academy, and thank you for your presence.
Esteemed members of the Academy, dear colleagues, I'm very happy and honored to be here this morning to discuss Aurora, the academic research program on the molecular profiling of metastatic breast cancer, sponsored by the Breast International Group and initiated by Professor Piccart. Please take a moment to review my disclosure information. As an introduction, I wanted to show how genomics medicine evolved in the last century and in decades. We have in 1952 the hint to the helical shape of DNA by the Rosalind Franklin photograph, to the discovery of the double helix, to cracking the DNA code to protein in 1961, and then some techniques that allowed us to decipher DNA. So in 1977, the Sanger rapid DNA sequencing technique, and then starting to link molecular alterations to disease, such as Huntington's disease in 1983, and finally, first evidence of the BRCA1 gene that is relevant to breast cancer in 1990. Now, in the early 2000s, research has accelerated because the human genome was decoded in two distinct initiatives that published back-to-back in Science and Nature. And following that, there were technological advances and a decrease in the price of the technology that leads us today to what we call precision oncology. The schema here shows you the precision oncology concept. So we meet the patient and then we collect samples, either tissue samples or blood. We perform different types of omic profiling. Data is interpreted. There's a management decision in a tumor board. And then a drug is prescribed, or if you found a resistance mechanism, a drug is not used. And then the patient is followed, and this can be repeated anytime we have drug resistance and progression of disease. Now we have moved in the clinic from biomarkers that were discovered using a single gene analysis to multi-gene analysis. So both techniques have advantages and disadvantages. So the single gene analysis is very sensitive, is less expensive, and can be done on tumor tissue and plasma. However, it can only look at known targeted mutations and at one mutation at a time, so we need to repeat that using more and more tissue. The multi-gene analysis is more expensive, but it can detect a wide range of changes in numerous genes. And again, it can be performed on tissue and plasma. So going back to Aurora, when this program was initiated, this was the state of the art. We knew that breast cancer evolved between early and metastatic disease, and that many initiatives have been studying the landscape of metastatic disease of mechanism of resistance to therapy. We also know that if we can provide this information to clinicians, treatment informed by sequencing of tissue or plasma DNA could improve the clinical outcomes of patients with breast cancer. Now, what did we know at the time? I show you here the study from the TCGA, where there was molecular profiling that was performed on a large number of breast tumor samples. The caveat here is that most of them came from primary disease. And what we can, was been able to show here that you had recurrent molecular alterations in the different subtypes. For example, PIK3CA, TP53, you can see them across the different subtypes of breast cancer, and that in the future could be targeted since they are recurrent. Now, we also learned that there is genomic evolution between primary tumor and metastasis, and this is why TCGA, that was focusing on the primary, needed to be followed up by multiple initiatives. And you can see here that you have truncal mutations, but at one point you will have metastasis private alterations. And if you want to look at the prevalence of these acquired alterations, you see that when you look at the most frequently mutated genes, it's only 5% of cases. However, when you look at rarer mutations, this can be as high as 45%, and this can be relevant for the treatment of our patients. Now, I said that there are other studies that looked at the genomic profiling of metastatic samples. I show you here two initiatives. This is the French initiative that used whole exome sequencing as a sequencing technique, and the Dutch initiative that used whole genome sequencing. Now, these initiatives collected data and samples in the metastatic setting and perform this molecular screening. However, they did not collect primary tumors, so we did not have pairs, primary tumor pairs, to really look at the evolution of this disease. And in order to show the genomic alterations enriched in metastatic breast cancer, they compared that to already published and publicly available databases. So again, I insist here, those were not pairs. Now, what we also learned is that when you study metastasis and samples from metastasis after multiple lines of therapy, you might be detecting the evolution of the tumor that is caused by the different treatments, and not really the early alterations that are making this disease metastatic, so causing relapse. So in this study of colorectal and breast cancer, the conclusion was that metastasis private mutations are not really drivers of cancer spread, but instead are associated with drug resistance. And in Aurora, one of our objectives was to identify the alterations that actually drive cancer spread, that are responsible for relapse, because in the future, if we target these alterations or prevent them, we can cure more patients. So I show you here the 4 objectives we were following: the understanding of advanced breast cancer with an integrated analysis of tissue and liquid biomarkers, to identify and track the molecular alterations responsible for metastatic potential and lethality, the development of a precision medicine infrastructure, and then, since we were giving the results real-time to investigators, the identification of patients with candidate driver alterations in their tumors that can be matched to biomarker-driven clinical trials. You can see here the Aurora study design. So patients were recruited early in the course of their metastatic disease, meaning either at the diagnosis of metastatic breast cancer or after only 1 line of therapy, because we really wanted to identify these early alterations. We collected the sample from the primary tumor, so this was archival, and we performed a new biopsy of a metastatic lesion. We collected FFPE and frozen samples from this metastasis. We also collected baseline blood to look for the germline alterations, plasma, to isolate circulating tumor DNA, and serum. And the patients are followed longitudinally, so they have regular follow-ups. We collect the baseline demographics and treatment information, and the follow-ups, all the treatment information, the subsequent treatments for metastatic breast cancer, including the response on these treatments, and also serial plasma and serum collection at every disease progression and every 6 months. Now, Aurora has recruited in 60 centers in 11 European countries. You see the distribution here. And I show you here the flow of the study. So as I said, we recruited the patients early in the course of their metastatic disease. The Breast International Group has set up an IT platform that would allow the centers to follow how the samples were handled, because the analysis was done in a central lab in Belgium. At the central lab, there was a pathology review evaluating cellularity, histopathology, and performing immunohistochemistry, again, for the receptors and HER2. And all the pathology images are scanned for future research, including machine learning research. There was some molecular analysis. There were some molecular analysis performed in real time. So this is targeted gene sequencing using a panel of 411 genes performed on both the primary and the metastasis, and a smaller panel of 27 genes on the baseline circulating tumor DNA, well, on the baseline plasma sample. In batches, retrospectively, we performed RNA sequencing and copy number variant analysis using OncoScan. Reports were generated on a real-time basis and annotated in a molecular advisory board. This was an international board that met virtually every 2 weeks and provided guidance on pathogenicity, but sometimes also on treatment, and feedback was given back to the clinicians. We have recruited in the first part of Aurora 2,000 patients. Half were screen failures, unfortunately, and this was for many reasons. When we look at the breakup, half of the screen failures were at site, meaning that the site failed to collect the samples, and half were screen failures at the lab, because some samples were really old from the primary tumors, so we had DNA degradation. From the biopsies, metastatic biopsies, sometimes there was not enough cellularity. And we have now, this can be updated, 1,100 successfully included patients. Data is being cleaned for a majority of those, and we already have a publication that looked at results from 379 patients. So as I said, it was interesting for us to look at the pairs, primary and metastasis from the same patient. So in this first paper, we really focused on the pairs, and for targeted gene sequencing, we had 242 pairs. For RNA sequencing, 152, and for copy number variant analysis, 67. And you can see here the distribution by the different subtypes. I'll show you here the patient and tumor characteristics. So as expected, the majority of patients with hormone receptor positive HER2 negative disease, 19% had triple negative breast cancer, and 16% HER2 positive breast cancer. Most patients were treatment naive in the metastatic setting, 72%. 28% had received one line of therapy as was allowed. A majority of patients had received prior neo or adjuvant therapy, including chemotherapy, endocrine therapy, and anti-HER2 therapies. And interestingly, in this first cohort, 14% of patients were treatment naive, meaning they were diagnosed with de novo metastatic breast cancer and at the moment of the biopsy had not received any type of therapy. This slide summarizes the molecular alterations findings. So I'm going to guide you through it, and I actually made a summary of what we found. So you see here the mutations that were detected, the copy number gains, and the copy number losses. Here we summarize some of the clinical characteristics, such as prior therapy in the adjuvant setting or even in the metastatic setting. And we also looked at subtype switching, so if there was a switch from the primary tumor to the metastasis, and I will detail that later. Everything you see in gray are shared alterations, alterations that we found both in the primary and in the metastasis. Everything that is in a different color is private to the primary or to the metastasis. So if I want to summarize what we saw, that 88% of point mutations in the driver genes were shared between the primary sample and the metastasis. This shows us that in early metastatic disease, we do not have a lot of acquired alterations, and that at least one driver point mutation was acquired in the metastasis in 10% of cases. This was more frequent for copy number variants, as this was in a third of the cases. Now, looking at the details, in this figure, we wanted to see what mutations were enriched in metastatic disease, because this could lead us to future treatment strategies. So those are the red ones for the point mutations. You can see ESR1, so this is a mutation in the estrogen receptor. This mutation activates the estrogen receptor in the absence of hormones, even when you give endocrine therapy. So this is a mechanism of resistance to endocrine therapy. Others were PIK3CA, CDH1, PTEN, and RB1 that is relevant when we treat with Cdk46 inhibitors, the agents that were discussed by Professor Du. On this slide, we did the same thing, but this time looking at copy number gains, copy number alterations, and deletions. So you see here that the genes, well, the typos are really small, but what I can say is that we found 3 enriched pathways: homologous recombination deficiency, epigenetics, and stemness. And these can be domains for future research. There are some mutations that were present in the primary tumor, but that were even more present in the metastatic sample, because the increase in clonality would be also a mechanism of resistance. So we studied that, assessing cancer cell fraction, and we selected for the paper 3 genes, so ESR1 again. So you see when cancer cell fraction increases, we have more endocrine resistance. The same for RB1, including resistance to Cdk46 inhibitors. And the RBB2, Mr. President, you discussed amplification of the wild type gene, but we also have somatic mutations that can occur in RBB2 that can drive resistance to therapy and that can actually be targeted. Now, we looked at some gene signatures. We were using targeted gene sequencing, so this was difficult. However, we could look at homologous recombination deficiency signature. So this is in part correlated to BRCA mutations, but can also occur in the absence of BRCA mutations. What we can see in this figure is that we had more homologous recombination deficiency in the metastasis, and this was really true for triple-negative breast cancer. So in the future, we need to target also, perhaps with PARP inhibitors, tumors that do not have germline BRCA mutations. Subtype switching between the primary tumor and the metastasis was important for us, because when you have a subtype switch, probably that the therapy that was used to target the primary tumor needs to be different in the metastatic setting. You can look at subtype switching using classical immunohistochemistry subtyping, and this is when a tumor loses the hormone receptor or loses HER2 expression. But we can also look at gene expression. So looking at the RNA sequencing data, we have subtypes of breast cancer that are the luminal A, luminal B, basal, and HER2 enriched that we can infer using RNA sequencing. And using RNA sequencing, we had intrinsic subtype switching in 36% of cases. And why is that relevant? Because some of these studies in the metastatic setting using the Cdk46 inhibitors show actually that you have a differential response to the Cdk46 inhibitors when you have a different intrinsic subtype. So palbociclib, in retrospective exploratory analysis, might not work when the hormone receptor positive HER2 negative tumor is HER2 enriched. However, ribociclib can still work. And this led to a study led by our Spanish colleagues of SALTI, where patients are randomized to ribociclib or palbociclib if they have HER2 enriched disease. Now, also using the RNA sequencing data, we looked at the immune signatures, knowing that immunotherapy in combination with chemotherapy is standard of care in a subset of triple-negative breast cancer tumors. So looking at that, we saw that there is a decrease in the expression of the immune score in the metastasis, excluding, of course, the lymph node metastasis because they are enriched in lymphocytes. And we saw that across the different intrinsic subtypes. We also tried to look at the immune composition of the microenvironment because we have data showing that metastasis could be more immune resistant. And what we actually found, well, this is a cybersode, but I summarize it here, that we found an increase in immune permissive cells in the metastasis, such as the T regulators or macrophages. Now, as I mentioned in the design, we have data from the outcomes of patients because we followed them. So we tried to look at biological processes associated with the worst outcome. And what we could see is that there is a gene, a mutation in a gene called LRP1B that is involved in the metabolism of cholesterol. Actually, when it's present, patients have a very dismal prognosis, and this is worse when the mutation is acquired. We also looked at tumor mutational burden, so the number of mutations per megabase, with the caveat that this is targeted gene sequencing and not whole exome sequencing. And what I see here is that when you have a higher tumor mutational burden detected in the primary tumor of hormone receptor positive disease, this is the blue, patients relapse much quicker. So these potential biomarkers can be incorporated in future clinical trials. Another analysis we did, as I said, we were reporting the results to the investigators in real time. So when you look at the alterations that are given, some can be used to guide therapy. And we used the ESMO scale called SCAT. So this is a scale to rank the different alterations. What is most interesting for the clinic are the tier 1 alterations, so ready for implementation, and tier 2, they are investigational in advanced clinical trials. In bold, you can see the alterations that were given real time to our investigators, and actually in more than in about 51% of cases, so more than half, we found at least one tier 1 or 2 alteration that could drive the therapy of the patient. Now, we looked at the use in the clinic. This is still dismal, so only 7% of patients in the first Aurora cohort have received targeted therapy. This is for many reasons. These are 11 European countries, so we don't have homogeneous access to drugs. The program started in 2014, so we have now better drugs being developed and more clinical trials. So I expect this number to be higher in the next reporting of the results. Then we also looked at the liquid biopsies. So as a reminder, when we collect plasma samples, we can identify we can isolate circulating tumor DNA that can be sequenced in the same matter as DNA extracted from tissue samples. And use is multiple. So we can use that for early cancer detection, surveillance for micrometastatic disease. We can use that to select the treatment based on the mutation that have been identified. Also monitor the efficacy of treatment. So in Aurora, this is very preliminary because, well, what has been published is preliminary because we started this analysis later. So in the first paper, we have results from 100 patients. Not all patients have circulating tumor DNA and identified mutations. And some mutations that you can identify in tissue samples are not identified in plasma samples and vice versa. So I believe that these results can be complementary, and circulating tumor DNA is interesting in patients for whom you can't make a biopsy because the lesion is not accessible. So moving to my conclusions, integrated analysis in Aurora shed light on alterations correlated with tumor progression and therapeutic resistance. And I'll mention here stemness, homologous recombination deficiency, and epigenetics. The tumor mutational burden is higher in metastasis and is an independent prognostic factor that could be integrated in future clinical trials. Intrinsic subtype switching occurred in 36% of cases and has clinical significance. Expression of immune signatures is lower in visceral metastatic samples of breast cancer, and metastases are enriched in immune permissive cells. At least one tier 1 or 2 alteration as per SCAT was identified in more than half of cases, paving the way for routine molecular screening of patients with metastatic breast cancer. Liquid and tissue biopsies seem complementary. Now, what are our perspectives? So there is a program extension that will start soon, recruiting more patients with lobular breast cancer, triple-negative breast cancer, or patients with a late relapse. Indeed, hormone receptor positive disease can relapse more than 10 or 20 years after the diagnosis, and we want to study these patients. We have a very large biobank, including FFPE samples and fresh frozen samples. And this figure summarizes the samples and data we have. We also have a clinical database and a lot of genomic data and the pathology slides. So there are Aurora working groups in different settings of the disease that are currently receiving data and in the future can access samples to perform future research. And these are our acknowledgements, as this is a really huge program with multiple people participating, different Breast International groups, the bioinformaticians, and of course, Professor Piccart, who initiated the program. And I thank you for your attention.
Thank you very much. Extremely interesting, especially also for the basic scientists. Questions from the audience first. Yes, yes.
It's not a question, it's a comment. It's the huge cost of such a research program and the difficulty to find the funding. So we took the decision not to involve pharmaceutical companies. Maybe it's a wrong decision, because AACR, for example, is doing a massive program like this one, but with 9 or 10 companies, and then you have all these contracts that you need to discuss, intellectual property rights. We have received most of our money from the Breast Cancer Research Foundation in the United States, which is interesting. So a foundation in the US collecting money from US people is financing a European program. It's rather unique, but the advantage is that you are totally free in terms of exploitation of the data, but it is a real challenge to get money. So one patient in this program cost probably something like 40,000 euro, and that's not taking into account some new investigations we would like to launch, like artificial intelligence. We think we should not have called the program Aurora, but Vertigo. Because I don't know how we are going to be able to study all the data we collect on each of these patients and the huge heterogeneity. So I think we will need to work with experts in artificial intelligence, and that means we need additional funding. So it is a real battle for the money. And in this country, it is very disappointing that we don't get support. So we got support from Luxembourg, from Fondation Cancer Luxembourg, a few private donors. But in Belgium, we have been unsuccessful, or we just got very limited funding, very, very small amounts, covering perhaps 10 patients. And it's a pity because most patients in this program are from Belgium. And some of them benefit from this extensive range of investigation. And I don't know what we can do for that, but I'm telling you, maybe the academy can have a role there, but it is a pain.
I think the citizens, the people would give money, as they do for Télévis, for Fondation contre le Cancer, but we have to probably gauge differently the purpose of this. So not to say it's just for PhD studies or postdoctoral studies. We have to show the dimension of the problem, that one serious study, to be really able to do it, you need much more money, and therefore we should set the bar very high. Like Cancer Research UK does that, in UK, in Switzerland does that. So we have to create a new kind of Télévis or a new kind of effort for the Fondation contre le Cancer, where we recently had calls. So you know, there are people are willing to donate money, but we have to create some new mechanism. Otherwise, I don't think with the FNRS mechanism that we have now and with the huge pressure and competition that we have at the moment, it's going to be very difficult. We have to open new lines.
Thank you for your presentation. I have perhaps a very naive answer, but do you observe specific characteristics in the metastase or of the metastase according to the distance in the body from the primary tumor?
So this is going to be, well, thank you for your question. I think this is going to be an aspect you want to study in the future. Not really the distance, but the characteristics of metastasis by metastatic site, because we can see that this can be really interesting. This could answer some of the questions we were asking about oligometastatic disease, maybe using molecular alterations, try to identify really the oligometastatic cancers. But also, for example, when you look at the immune profile of the microenvironment, we looked, I did not show this out, but we looked by metastatic site, and obviously in the liver we saw that there was really an increase in the immune permissive cells that we did not see in other organs. So yeah, organ-directed research is going to be something very interesting in the future of the program.
In the world of investment funding, there are a lot of funds that want to have very high level of investment. If you request 10 million, they don't get involved. If you request 500 million, then they're interested. Because they say that if they send people to the boards of all these small things, they will exhaust their resources. So the trick is to request a lot. And if you have a name. Yeah. Well, there are many of them in the US. Management Portfolio Capital, MPM, for example, does this type of thing. So probably the mechanism is to create some kind of a biotech company that then needs to be funded, but to keep your scientific independence and not to have financial priority. That's the big problem. The digital world?
No question on internet.
Well, since we are really, really in time, if the organizers want to say some closing remark,
just thanks again, but I already said it, thanks to the Academy and thanks to the lecturers. I think that with Martine, we had the chance to build an interesting program focusing on localized cancer and on metastatic disease, trying to show how things are evolving in this field in terms of treatment. Thanks for the audience and have a nice weekend.
Thank you very much again, and a round of applause to the speakers. Thank you. Thank you. Have a good weekend. Thank you.
On va interrompre.